Okay, so I think we'll go ahead and get started. I'm getting quite a few emails of people re-registering, so I think that we're going to have a couple people joining us here in the next couple minutes. But I just wanted to say thank you all for joining us today. I am when I first started back at the Alliance last summer, this was one of the events that I was most excited about, was the opportunity to kind of plan this, what we were calling then the QI conference, that was supposed to be back in May, and then the world kind of flipped upside down, and now here we are doing it virtually as what we're calling a workshop. But I'm still really excited about the content we have today, and I still think we have great presenters, and we really are looking at the goal of expanding the quality discussion beyond just the quality improvement folks in your health centers. And I think we did a really great job of that today. You'll see later in a poll, we have really great representation from all different departments, all different service lines. And then we have great actionable steps that we'll be providing you through subject matter experts, and then by learning through your community health center peers. So I just want to say thank you all for joining us. This conference / workshop is a partnership with the ADHS. So I do want to provide the opportunity for our ADHS colleagues, Tanae Turner-Warren and Rachel Sally, if they're on the phone, to just unmute themselves quickly and say hi.
Okay. Rachel?
And if she's not on, that's okay.
I wasn't sure if she was going to join us or not, but I'm just going to do a little quick intro. So my name is Tanae Turner-Warren, and I'm the Heart Disease and Stroke Program Manager at ADHS. We're housed in the office, well, I'm housed, my position is housed in the Office of Chronic Disease, which is under the Bureau of Chronic Disease and Health Promotion. We're a very small office, and I manage the federal dollars that goes towards the heart disease efforts in our state. And some of that includes working with partners such as the Alliance, universities, FQHC, community health workers, tribal partners, and others. And the focus mainly is to implement best practices for cardiovascular disease prevention program, which kind of includes this QI conference that QI workshop, that we're on today. And with that, I would like to turn it over to you, Lainey.
Great. Thanks, Danae. And again, just wanted to quickly hop on and say hello, welcome. Thank you for being here. We do have a couple polls that we're going to launch for you really quickly. So Rebecca, I don't know if you can help me out and throw those up.
Lainey, real quick, Rachel just got on.
Oh, okay. Let's see. Hi, Rachel. I just did a quick introduction and let everybody know just that this is a partnership with ADHS. So Tanae just hopped on and said hi really fast. And if you want to, you can unmute yourself quickly and say hi, but no pressure also.
You're muted.
Yep, just unmute yourself. Okay. We'll let you say hi in the chat just so we can keep on moving forward. But great, I do see, awesome. So how well do you think your health center or organization is managing patients with chronic disease during the time of COVID? So average or well, it's pretty good. Hopefully we'll see some improvement over the course of this this conference, but good. I'm glad that everyone feels like they've got at least a decent handle on it. So thank you. And then how well do you think your organization does working cross-departmentally to address optimal patient outcomes, average or well again? Great, perfect. Okay, well with that, thank you all for participating in our polls. Great. I'm going to turn it over. Actually, we have our FrameShift folks who are here today to help us with the facilitation of today's workshop. So I am going to turn it over to Rebecca and Peggy.
Hi, my name's Rebecca Nevedale, and I'm one of the facilitators today. And I'm with Dr. Peggy Stemler. So Peggy, do you want to say hi?
Hi, everybody.
We're really excited to hear from the expert speakers that AACHC has lined up, and from all of you too. So Lainey said, this is a workshop, not a conference, and it was really intentionally named that way because we're trying to do things a little bit different. And I know that a lot of you have attended AACHC conferences before for quality and other workshops, But that was before these virtual meetings were our new norm. I mean, this is how we meet now, and we're all still learning how to make the most of that. And what we need to do to really get information from our colleagues doing these platforms. And I know for me, when I go to conferences or meetings or workshops, I get the most out of lunch break, the breaks in the exhibit hall, the wine time, the poster sessions, because I get to really talk with my colleagues and dig in to the stupid little things that they do every day that really make a huge difference in achieving outcomes. And when we're meeting virtually, we don't get any of those opportunities. So it really puts a lot of pressure on us to make the most of the time during the presentations and the discussions to get out of our comfort zones and really interact with each other. So we are going to spend some time, just a few minutes in the morning, going over the Zoom things and trying to help people practice doing that. So we're going to start with another poll here. And I think that some of you may have had trouble seeing the poll because only about half of you participated. So if you see a poll in front of you, please tell us what role you have in your organization. If you don't see a poll in front of you, if you have two screens, you're going to want to look to see if it popped up on the other one. If you also have open your email or a spreadsheet or Facebook, you're going to want to X that screen out because the poll probably popped up right underneath of that. And if you're still having trouble, go ahead. A lot of you have already found that chat box in Zoom. So go ahead and chat in and somebody will help you troubleshoot with you. So we have quite a few polls today. We're only going to give you a few seconds to answer most of them. So, all right, I will launch that or share those results here. So not surprisingly, most of you are from the QI department. It's a QI conference. It's a QI meeting. It's a QI world. So we love our improvement people. But it looks like we have quite a few medical providers and C-suite folks too. Shout out to our single dental person. We think you have more dental friends coming today. We really are excited that we have a pretty good representation of folks who've registered today from different departments. And we want to make sure that everyone recognizes your voice really matters. So just because you are not in the QI department and it's a QI meeting doesn't mean your perspectives aren't going to improve those QI folks in their health centers. So please share those perspectives. And just because you're not a physician doesn't mean your voice doesn't matter either. So, and most of the presenters that you'll hear from today who are physicians, you'll hear that common theme that this was done with the whole team. So please make sure that you recognize everyone's perspective is really important. And we're also excited that we have a pretty good representation of not all the counties in Arizona, but quite a few. So most of us logging on today are like me, calling in from Maricopa County, but lots from Coconino County, from Pinal, Cochise, Yavapai, and some Mojave County too. So it's always better when we get, state representation. So we do have time for discussion after each presentation, and we really hope to hear your voices. And to hear your voices, you're going to go on the bottom of that Zoom window. On the left side, you'll see mute. So can some brave person practice that for me? Unmute yourself and say hello.
Hello.
Hey, lots of brave people. I had thought of all of these different questions to ask if I got crickets. So my next one was Coconino County. Is anybody calling in from Coconino County? Can you tell us what temperature it is?
I believe it's 70.
Okay, so all of us in Central and Southern Arizona are very jealous of you. I'm glad you all found that. It's not that scary to mute or unmute yourself. And if you hear yourself 15 times because you have an echo, Lainey emailed you 2 days ago. You got an email from Lainey Plattner, and there were some tip sheets on what to do with audio issues, or you can chat it in and one of us will be able to help you. But feel free to also copy and paste that tip sheet and send it to everyone you work with so that you don't waste 15 minutes of every meeting hearing echoes. So, and we do hope that you will use that on next to the mute button is the start and stop camera. So we hope that you will push that now see if we can get some more faces to pop up. When we're talking with virtual, when we're doing these virtual meetings, it's really important that you try and figure out how to connect with your colleagues so that you can learn from them. And seeing faces is better. And I can see Anita's already moving her camera around, which is awesome. We know a lot of you have multiple people in the same room, so we want to see all of you. So the next thing we're going to do is show you how to toggle between different views. So if while I'm talking now, you can only see my face, you're in what's called the speaker view. And if you hover on the upper right part of your Zoom window, you're going to be able to see this little box. And if you click that, it goes to gallery view. So then you see like Hollywood squares. And you can choose which way you want to look at things. I personally like to look at the presenter when they're presenting. And then when we're in discussion time, I like to look at the Hollywood squares. So, but a lot of people don't know you can switch back and forth. So we thought we'd show you that.
And you can't really do it when we're sharing a screen, but when we stop sharing screens, check it out then.
Oh, okay. I didn't know that. See, one of the things we have to all do, like as we're moving virtual, is just practice forgiveness. Because nothing happens, and most of us aren't IT people. We have a few on the screen. Us non-IT people probably freak you out the most because we have all these simple challenges. We do want to know make sure if you're talking to each other, you know where you're from. So we're gonna change all of our names now. So this is part where you have to actually do something. So click on that participants box. And you're going to get a pop-up with a whole list of everybody who's on the meeting. And then you're going to find your name. You're going to hover over your name, click on where it says more, and then click on rename and it'll pop up. And we want you to say your name and your health center. And if you're having trouble, make sure you chat it in. Somebody will help you. We want you to be named your name and your health center. This is just going to help. Well, it's going to help some of you know people from your health centers are logged on, which would be great. Maybe you can have another virtual meeting with them later and find out what you all learned. But it's also going to help you be able to share with other people in your community, or maybe just hear about rural medicine in Chiricahua if you're in Coconino, or vice versa. So, and it looks like people are doing it. Yay. All right, next is the chat box. I know a lot of you have already found that chat box. The chat box, for this meeting, if you hear something that strikes you, just chat it in. If you want to hear more information about an idea, if you really want to dig in with someone, maybe you're a suite leader and you hear about something that a health center's outreach department's doing, and you're wondering, do all outreach departments have access to that program or do things in a similar way? Go ahead and put it in the chat box, and someone who works in outreach in another center can answer that question right away. We really want that to be a tool for you. There's over 100 people on this call. As much as we want to hear everyone's voices, we know we really can't. And some people are just unwilling to unmute themselves or not extroverted and learn better through the chat. So however you are going to learn best, whatever's going to help you stay present and stay focused and pay attention, we want you to be able to do that. And we're going to try to not have people raise their hands, but if you do want to raise your hand, you probably already saw that is in that participants box, which is already chatted in there. So that's all the Zoom things. If you have questions about how to operate Zoom, chat them in. But I think most of us are kind of Zoom professionals by now. I'm going to launch another poll, and we're only going to give like 15 seconds to answer this. So which of these statements do you agree with? And you can select all of them. Okay. So I'm going to share our results here. So, okay, well, not surprisingly, people who work in clinics have a hard time sitting down. That's because you really don't do that on a normal day. It is hard, I think, to stay engaged in virtual meetings sometimes. A lot of people don't like using your cameras, but many of you have them turned on anyway. So we are thankful for that. I think whatever you need to do to stay engaged, if it helps you to crunch on baby carrots during a meeting, go ahead and, crunch away, just mute yourself. We all eat snacks. We all eat. We all get hungry at 10 o'clock in the morning. So knock yourself out. If you need to stand and stretch, just stand and stretch. Be mindful of what body parts the camera's on, but otherwise we don't mind. And, we really do need to practice being forgiving, and we need permission to just be a little more human, because cats run across computer screens and kids come charging in and Amazon delivery drivers drop packages off and all the dogs go nuts, and it's all okay. Whatever you need to do to stay focused, because what's most important is that when you're logged on, you're present and you're not answering emails and you're listening to understand. This is really a unique opportunity at a point in time where, we will record the sessions. You'll be able to listen to the presentations again, but we won't be recording the discussions. We won't be posting the chat. So it's really an opportunity for you that we hope that you just take advantage of. So, and really, has there ever been a time where getting the brain trust and the knowledge of everyone has been more important? Because we're all learning, every day how much everyone's role really matters. So I am going to turn it over to Peggy, and she's going to talk a little bit about her perspectives of the day. But I'm going to launch this poll, and Peggy, you can go ahead and get started whenever you want. I'll close this in about 15 minutes. We're interested, and we thought you'd be interested to hear from other health centers. How have you been surviving? What kinds of things are you doing that you think are making a big difference?
So thanks, Rebecca. And as you're looking at the poll, I'm going to start with just a picture that I love. And thinking about the time right now, this is just this beautiful idea. The barn's burnt down. Now I can see the moon. We're in that time right now. I mean, we're in a time of life where everything that we knew 6 months ago has changed. And with that change, we all have to figure out how to do things in a new way. So the title of this conference, this idea of returning to usual patient care in unusual times, I mean, this is a moment in time where you guys have this enormous opportunity to do some cool new stuff. So given that, we also know that you are kind of the change people. You're the people who run towards these ideas and not away from these ideas. And we also know that you're working with a lot of people who are in that bunker right now. Like, my world has been completely turned upside down, and I'm going back to the things I know because that is what makes me feel safe. We also know that that's not going to make anything better, which is kind of the hard part about it, right? So you're kind of figuring out, how do you work with all of these new ways of doing business? This is not really necessarily disruptive innovation at this point. It's a disruption that is allowing you to be innovative. Sort of a little bit different twist on that. So again, the cool thing about here, it's a virtual meeting. We know that one of the best parts about in-person meeting isn't necessarily what you're hearing from other people in that kind of presentation time. It's when you can go off and have a cup of coffee and pick somebody's brain there. So as you are going through today and hearing these new ideas, think about who you want to connect with next week. What are those things that you're hearing? Well, yeah, it might not fit your center exactly. There's always somebody else that has opportunities that you think to yourself, I'm not going to have those opportunities, but what can you learn from the things that they are now learning? Because nobody here today is going to talk about something that they've polished up into a done deal. Everybody is still learning how to do things differently right now. So take advantage of your friends, take advantage of your, your kindred spirits, people who are really embracing this move towards how do we really work together towards these better outcomes, and run with it today. And as Rebecca said, kind of share ideas, in the chat. If you just want to say, man, I want to check in with this person later. If you don't already know them, ask for their email. Say, hey, how can I get in touch with you? We really hope that the ideas that you're hearing today trigger work that's going to happen, as you all know, over the next few months and maybe even longer. So make some new friends today, even if it's a virtual friend. It has a new meaning today than it did when we were all little. So go enjoy what you're doing today. Try really hard to be present, which means shut down your email, turn off the phone, try not to look. It's really hard. Everybody is pulled in 85 different directions, but be here and connect. And really, when you're, the people who are presenting today are looking for your ideas as well. So share them back. Thanks.
Thanks. And we are going to jump in where we all should be thinking of first with patients. So I'm going to turn it over to Tiffany Christensen from the Barrel Institute. And Tiffany, you can go ahead and share your own slides, but why don't you introduce yourself a little bit?
Thank you so much. Hi, everybody. Good morning, or wherever you happen to be on the time zones. I am Tiffany Christensen. I'm really excited to be here with all of you today to talk just a little bit about some of the most recent research that we've done at the Barrel Institute that may be of service to you as you are looking at your current state and where things have the potential to go from here. So I'm the Vice President for Experience Integration at the Barrel Institute, and I did just want to share a little bit about myself. And while I'm doing that, I would love for you to share a little bit about yourself. So while I'm talking, if you want to grab that chat box and take a moment to introduce yourself via the chat and let us know where and how you are doing today. Maybe just one or two words, think emojis. I'm excited, I'm anxious, that kind of thing. And then we can kind of just hear from everybody, and that would be great. So I come to this work primarily as a patient, I would say. Oops. And the reason for that is that when I was born in 1973, I was diagnosed, I've got a little problem with my slides here. I was diagnosed with cystic fibrosis. And so I was fortunate enough to be able to, gosh, that's annoying. Hold on one second. I'm gonna pause this. I know how to fix it if I get out. Sorry, guys. Let me just take 2 seconds, and while I do that, if you would be so kind as to go ahead and fill out that chat, and then we can come back together in 2 seconds while I fix these slides. Let's see, oops.
Looks like and there's also a discussion going on too, for those of you who aren't in that chat, that there's a question about how folks are handling childcare furloughs and things too.
Oh, great.
Yeah, which is kind of neat.
All right, 2 more seconds. There we go, I fixed it.
All right.
Okay, I'm gonna share again, sorry. Okay, well, let me look at this chat real quick. Oh, nice. Great to see all of you. All right, so, oh. Hold on. Every time I start to think that I'm a Zoom expert, that I'm not.
That's why we reminded them to be forgiving 900 times.
There's always something that I do wrong, it seems.
Primary care people, they've been doing telehealth visits. Nothing can be, they've seen some crazy.
They've seen some stuff, yeah. Okay, so let's hope this works. So again, cystic fibrosis patient, lucky enough to receive a double lung transplant in 2000. Unfortunately, that lung transplant didn't last as long as we had all hoped. It was only 2 years and 2 months after that that I was diagnosed with chronic rejection. But again, lucky for me, I was able to have a second double lung transplant in 2004. So that's been a long, long time ago, and these lungs are doing really well. Unfortunately, my kidneys were not a fan of the immunosuppression drugs that we're on, though, so I am now a dialysis patient looking to hopefully get a donor kidney at some point in my future. So I've had a lot of experience as a patient, and after that second double lung transplant, I was invited to be a patient advisor. And that was really, it was actually at Duke, and I'm in North Carolina. I get treated at UNC, but Duke asked me to be on their patient advisory board. And so I joined that. And it was really the first time that I would, as a patient, had the opportunity to see some of what goes on behind closed doors in healthcare. And it was really shocking and kind of surprising to me just how challenging everything seemed to be. So I got really interested in the world of healthcare. And so for about 3 years, I worked at Duke as a professional patient advocate, working in the area of complaints and grievances. I then moved on to the state level, working on patient family engagement strategies through our hospital association in North Carolina. And then eventually, lucky for me, I got to join the team at the Barrel Institute focusing on patient experience. So at some point during this journey, I had, I guess, kind of like I just said with the whole Zoom thing, I had gotten pretty confident that I was a professional and I knew kind of the things that I was working on, and I was an expert in my own right. And one day I was in a hospital rounding on oncology patients, and I was asking them questions about their care. And these are questions that I thought were real smart, you know, things like when the team comes in, or the doctors and the other team members come in to talk to you about your treatment options and plan, do you understand everything that they're telling you? And I had this one patient, and I would ask her a question like that, and then she would reply with an answer that didn't really seem to match the question. So I would ask her a question like that, and she would say something like, I have this really intense pain on my left side. And I think to myself, okay, I must have really done a bad job asking that question. Let me try a different question. So then I would ask another really smart question, like, when you ring your call bell, do people come and take care of you in a timely manner? And she would respond to a question like that with, telling me how long it was that she waited in the ER before coming up to the floor. And so this happened multiple times, and the whole time I'm sort of thinking, wow, I really stink at asking questions because she's not answering anything that I'm asking her. And then it finally dawned on me, oh my gosh, I am asking the questions that I think matter, but clearly what she's telling me in her answers are that those things don't matter to her right now, because being a patient is largely a physical and emotional experience that happens internally. And if we aren't attuned to that, then we may be focusing on things that don't really matter to the person who's sitting in front of us. So this was a light bulb moment for me, in the sense that I realized that I had to be aware of how I was oriented in any given moment when I'm thinking about improvement in healthcare. It's not that it's wrong to try to figure out whether or not the call bells are being answered in a timely manner. That has to be done. But it also can't be that I forget about the actual lived experiences of those who we serve. And so when you look at this picture, some people see a duck and some people see a rabbit. Both are correct. This picture is a duck and a rabbit. And so how do we honor that in considering how we are oriented during any improvement work that we're doing, and especially during this crisis. How are we oriented? So one of the things that I wanted to share with you today, and sorry, once again, technology, I wanted to share with you some new hot off the presses data that came out of the Barrel Institute, something that we do quarterly that's called PX Pulse. One of the things about data that we all know that can be frustrating is that when it's lagging data, we don't really know if it applies to our current state. Well, take the COVID-19 crisis, and that becomes tenfold more true. So one of the things that's great about PX Pulse is that it does happen quarterly, so you're making sure that the data is keeping up with the moment. So lessons from this moment. These are all things that you already know that we're dealing with right now in this crisis. We're trying to figure out how to reopen operations, and a big piece of that is helping patients or consumers feel safe, reassessing visitation, or in your cases, having loved ones accompany patients, and then, of course, recharging the workforce, you all who are potentially exhausted, frustrated, all of those things. Then there's the financial realities, of course, that come with all of the complexities that are happening right now. Addressing health disparities and policy opportunities are things that we're seeing since emerging as really high priorities, especially given the state of unrest after George Floyd's murder. So we're seeing a lot of focus now on how do we do this work better. And then, of course, maintaining COVID care and continuing to think about our plans. So one thing that may be helpful is to look at some data around where we are with some of these issues. And this is, again, a collaboration that the Barrel Institute does with Ipsos quarterly, and every quarterly report is 1,000 or more surveys or people. So hopefully that's helpful. All right, so when we look at our first little piece of data here, we find that we're still right around 50 to 60% of people who feel that the quality of healthcare in this country is very good or good. And the question that I have is, will we start to see that trend up or down based on the COVID-19 response and the personal experiences people have coming back into healthcare? I think we have a real opportunity right now because of the fact that there is so much focus on healthcare, and that there is this greater level of real appreciation for the healthcare providers in our lives, that this could be an opportunity for us to take that data point higher, because we can really start focusing on partnership and the common humanity that we're all experiencing in COVID-19. I think that is a potential beneficial outcome of COVID-19, is this shared sense of purpose, shared sense of urgency, shared sense of humanity. So how would you rate your overall experience in the last year? We see that most people, the majority of people, report a very good or good experience. And again, that number is going to move based on, how we continue to move forward. And so one of the things that we want to talk about today is not only where we are now, but what does the new existence look like? One of the things that the Barrel Institute has been really clear in saying is that we're not really looking for a new normal. We don't really think that there is a new normal. Everything is going to be different now moving forward. So we're really talking about a new existence. So what does that new existence look like for you all? We're going to talk about that today. So when we look at what consumers or patients and families care about, We see that the majority of these things, having affordable insurance options, out-of-pocket healthcare costs, access to quality hospitals and treatments, and cost of health insurance premiums, we see that a lot of these are pretty stable. The one that has moved significantly, however, though, is access. And so this continues to open up that question of what does access mean in the time of COVID-19? And so some of the other data points that we'll see really start to answer that question. So this is something that you all already know. I don't really need to tell you this, but the survey did sort of confirm what we already know, which is that there is a great decline in the amount of people who are utilizing healthcare right now. Visiting primary care providers has dropped 26% from December 2019 to June 2020. So again, how do we help people feel safe in coming back? So this is an important piece. What is their level of comfort in seeking healthcare? You'll see here that going to primary care providers and a specialist provider are the two areas where people are actually most comfortable, highest rate of comfort across the sectors. So I hope that that gives us a little bit of hope that all is not lost, that even though there has been this 26% drop in utilizing primary care providers, that we are understanding that people are still having more comfort with that sector than they are, say, with urgent cares, emergency rooms, hospitals. So this can give us a little bit of hope that there's an opportunity to leverage that and to just take it up a notch. And then, of course, you already mentioned this, a lot of you are doing a lot of telemedicine right now. So how will you know, as we think about the future today and the future, how will you know when someone is better suited for a virtual meeting or visit versus a in-person meeting or visit? And there's lots of different clinical aspects to that, of course. But when you look at it through the lens of patients and families, they're telling us here that there are different reasons why they would want virtual versus in person. So the blue line is a preference for video conference call. The green line is a prefer to visit the provider in person, and the orange is don't have a preference. So one, we can understand that there may be differences in why someone would want a conference call versus an in-person. And second, that there is a lot of opportunity there for people who don't have a preference to be guided in a way that makes the most sense for you and for them. So how are we going to help them in the future with that kind of guidance? So we see that a lot of people, 62%, report that they are accessing online portals or apps to obtain health information. So that's exciting to see that a lot of people are utilizing that resource. And the number one reason why they utilize that resource is to review test results and doctors' comments. So the question that I have when I look at this graph, and again, blue is always, green is usually, orange is somewhat, and the light orange is never. So for example, at the bottom there, we see a great opportunity for patients and families to ask providers questions about medication through these portals, or ask providers questions about diagnoses or treatment plans through these portals. They're not utilizing it for that purpose. So how can we continue to partner with our patients and families to maximize this technology, again, both for their benefit and for your efficiency? So I'm going to pause here and ask for a chat. When you think about what we've reviewed so far, what actions can and must we take to ensure people feel comfortable and safe in returning to seek care? What do you all think?
Feel free to unmute yourselves too.
Yes, please either chat or unmute and tell us.
Hi, Lainey. This is Aurelia at Circle of the City. So I'll say we're actually in a unique position in that we have not utilized telehealth as much as perhaps some of the other centers. And I will say that one of the things for our patients as far as getting them in the clinics and helping to ensure confidence is helping them to understand what our protocols are. So to clearly post kind of what we're doing, what the expectations are, masks, and then just to see staff visibly following all of those protocols, I think has been really helpful.
Great, thank you. Knowing my provider is taking the utmost precaution, what their protocols are. Yeah.
So this is Eddie Estrada from Sunlight. I don't know, I have to turn this around. I cannot see. So one of the things that we did at the beginning of March was to track down the visits right away that we were having. So, and we have all that data, but right now in front of me, I'm looking at what we have in the last 6 weeks, 8 weeks. Average would say we experienced a -8 to 10%. Fluctuating in that point, actually around the numbers is 7.86, but negative visits. But we are doing televisit. We did not experience so much use of the televisits. And I believe the difference for us was that we remain open. All the services fully available to our patients since the very beginning of March. They didn't know we were open. We continue publicizing them. When they started to come over, we saw an increase in patients once the first hit was better. So right now, we are experiencing this second round, but not as acutely like in the first time, because we were -15, -20%, and now we're about -8, 7%. And it's because they knew then that we were here for them.
Right.
And they prefer to come face-to-face in spite of all the education that we do. When they walk in, they see what we're doing, and they feel comfortable. You know, all the precautions and everything that we do. So I believe it had to do probably with that strategy at the very beginning of it.
Yeah, thank you. That's great to see that you've been able to move that needle. So it shows that what you're doing is working. I love some of these examples too that we've got here in the chat. This doing screening outside so that people feel more comfortable knowing that they're not in enclosed spaces before they get screened. Ensure that patients and families know that we're following CDC and local state guidelines. Interviews with local Facebook page called We Love Nogales, and our CMO and providers go on and answer any questions as well as share data. That's really cool. I love that ability to use social media, but also I love that people are answering questions from the community. That's really an interesting and I think powerful approach, and one that really leads us into the next portion of our conversation. So thank you all for those responses. One of the things that we talk a lot about at the Barrel Institute is something that came out of a white paper that we wrote in 2018 called To Care is Human. And it's this idea that healthcare is a relational business that has been built on a transactional model. So what a lot of the patient experience work is that we're talking about is this concept of how do we build a relationship even though it's a transactional model. And sometimes that can effectively look like an afterthought of sorts. So the question becomes, how do we operationalize caring, quote unquote, in this moment? And one of the things that we know intuitively as people who work in healthcare, but also from our data, is that the way that we operationalize caring is to listen. So we see here that patients and families tell us that the number one thing that shapes their patient experience is whether or not they've been listened to, communicated with in a way they can understand, and treated with courtesy and respect. So you can also see here what the lowest ranked items are for patients and families. And one thing I'll just say very quickly before I move off of this data point is that I think it's interesting when you look at all the blue dots collectively and you look at all the pink dots collectively, they both have something in common, and that is that all the pink dots are something that requires a budget. All of the blue dots do not require a budget. And so I think sometimes when we worry about, whether or not we can execute on patient experience plans and ideas, we say that we are limited or unable to do so because of our budget. And the reality is everybody needs a budget. I'm not saying that you shouldn't worry about your parking lot or the food or whatever the case may be, amenities. Those things matter, but at the end of the day, there's nothing holding us back from moving forward with our patient experience work, because what matters most to patients and families is budget neutral. So we obviously know that there's a literal need. When we talk about listening, I think that the question then becomes, what does listening mean? Because I'm sure that a lot of patients and families have a different idea in their mind when they say that they want to be listened to. So we know that there's a literal need for listening. This is just one example. We see that the Journal of General Internal Medicine did another study around patients being interrupted. And on average, patients have 11 seconds to explain the reason for their visit before a physician interrupts. And that has gone down from 19 seconds. So there's this concept of slowing down and literally letting people finish their sentences. But it gets deeper than that. It also is about building organizational capacity and listening as an organization. So leadership commitment is required for that, and understanding the broad perceptions of your community, also being willing to capture those lived experiences and perceptions, and then prioritizing to make your experience efforts a practice. So listening as an organization is going to ensure that there is a sustainable process by which to capture what your patients, families, and community members are worried about and focused on. And then utilizing multiple strategies to hear from your community members is something that we don't talk a lot about. We tend to pick one strategy and think that that will serve the purpose of deep listening. All of these strategies are very good, but in an ideal world, you would be using multiple strategies simultaneously, whether that's focus groups, doing phone calls, or talking to people during appointments to understand their perspective, building a patient-family advisory council, simply shadowing and observing them as they move throughout your practice, peer rounding, which is a way of utilizing other patients and families to talk to patients and families, because they will tell their peer something different than they will tell you, more than likely. And then, of course, as we've looked at today, utilizing surveys. So listening comes in a lot of shapes and forms, and we can start to understand what our patients and families need, what are the things that are barriers for them, and what are things that might be able to really help them move forward and feel comfortable. And in addition, we can also start to think about what is meaningful participation when we're trying to come up with our strategies for listening. What does meaningful participation in healthcare mean to our patients and families? So I found this surprising when we asked which of the following actions reflect meaningful participation. I was surprised to find that the number one thing that patients thought of when they thought of meaningful participation was having open access to their medical records. I would have never anticipated that. And then partnering with my healthcare providers in decisions. I'm glad to see that. I'm glad to see that evolution that we have in healthcare today, where patients and families are interested in being engaged in shared decision making. And then surveys, would have never thought that that would be number 3, to be honest with you, of meaningful participation. And then for those of us who are big advocates of patient and family advisory councils, sort of surprising also to see that it comes close to the bottom of this list of meaningful participation. So one of the things that I would ask for you to consider is, do you know what meaningful participation for your community and your patients and families really looks like and is? So it's important, the data shows this over and over and over again, it's important for patients and families to have a good experience when they are receiving healthcare. And here are the reasons that are paramount for patients and families. We also sometimes use the word consumers, which I know for some people is a dirty word, but it really just means people who are not professionals that we are asking patients and families what their perspective is. So my health and well-being is important to me. That's the number one reason why patient experience is important. I want my physical needs to be taken seriously. Good patient experience contributes to good outcomes, which I think is a pretty interesting number 3, because that shows a high level of insight to be able to know that. And then I want to be addressed as a person, not a disease, and I want and deserve to be treated with respect. So again, these mirror some of the things that we saw in the earlier study about listen to me, treat me with courtesy and respect, and speak to me in a way that I can understand. So what do you think? Here's another chat for you. Where can and must we focus our effort to ensure people feel engaged meaningfully in their care? Where can we and must we focus our effort to ensure people feel engaged meaningfully in their care? This might mean how would you engage them as patients and families who are coming in to receive care? And it also might mean, how are you planning on capturing that information about patients and families and what's meaningful to them?
And feel free to unmute your lines as well. I know that there was some chat earlier about updating the patient surveys that you typically did anyway. We'd love to hear a little bit about what you learned with that down in Mariposa too. It will be a very boring day if we don't unmute our lines.
So we've got, I believe the most important way that a healthcare team can engage a patient is by listening. With the pressures of seeing more volume in our PPS focused environment, but feeling heard and cared for by their healthcare team will help patients return. Absolutely.
Mm-hmm.
All
yeah,
right.
I wonder too from the, you know, there's a few care coordinators on the lines too, because you would think that listening from the provider clearly, you know, super important, but there's other folks that yes, can listen to patients and then be the voice as well. And I'll give you just a quick time check too, Tiffany, that we're going to break in about 6 minutes.
Okay. So I see another one, assessing the patient's goals and what they want to focus on in their care. Yeah. Enhanced services available via the portal. There tends to be a gap in portal access for adolescents, so there's an opportunity there. Awesome. Great. I'd love to see all these suggestions, and please keep them coming. At El Rio, we updated our patient survey to gather information regarding their telehealth experience. as well as their in-clinic experience during this time. Great. So it's great to see that so much work is already being done across your organization. That's really inspiring and hopeful, and I hope that you can continue to learn from each other, because obviously you don't have to reinvent any wheels. If somebody is already doing something, you can just shamefully borrow their model and try it out for yourself. So I'd ask that you keep on sharing the things that you're doing so that your colleagues can see as I wrap up over the next couple of minutes. So as I mentioned earlier, there is this idea at the Barrel Institute of the new existence, not a new normal, but a new existence. And so currently we are balancing this crisis, the moment that we're in right now, in which we're trying to help patients and families feel more comfortable. We're asking them to come back to our care. We're trying to figure out what it is that's going to help them to feel safe. So that's the current crisis. And then we also have the new existence. Where are we going from here? For example, as was already mentioned, that, you know, we went from, oh, telehealth isn't really something that we can do widely for this, that, and the other reason. And now all of a sudden telehealth is something that we can do. So where do we go from here? What does the future of telehealth look like? And how are we going to leverage the lessons that we have learned during this crisis to help us create a new existence that is beneficial to you as the healthcare professional and to patients and families receiving your care? So that's just one example as we look into the new existence, but the future really depends on what we do today and tomorrow and the next day and the next day. It depends too on the recognition that at the heart of healthcare overall is our humanity and the human experience that's provided. And yet we still have work to do. The future of human experience is not waiting for us to arrive. It's waiting for us to build it together. So how are you going to build it together as a team within Arizona Alliance, but also how are you going to build it, co-design it, and co-produce it with your patients and your families and your community? That's a question that I would challenge you all with, because we are in a moment of crisis, yes, but we are also in a moment of great opportunity. Everything is sort of up for grabs. Everything is in a state of flux. And therefore, this is the moment to make meaningful change. This is the moment to understand what is stressful to your staff and to your providers, and how can we change that so that it works better for them? What is stressful or not effective for your patients and families, and how can we change it so that it's better for them? This is that moment of improvement. So hopefully we can ensure that all of the voices of those engaged in healthcare are heard, respected, and acted on. Advocate for and act to sustain processes, practices, and policies that have and will support experience excellence. Address systemic issues that undermine our capacity to support the health and well-being of all global citizens, and co-create a future in which new possibilities sprout from the deep roots of human experience. That's what we hope for when we think about the new existence. So as I leave you all with these thoughts, please go ahead and chat in one last time. What do you believe will be the most critical area of focus as we look at our new existence fostered by this current health crisis? I want to say thank you all for listening today. Thank you all for your time. I hope, I really sincerely hope, that this was useful for you, and that having some of this data of where we are in our current state, number one, supports you in your efforts moving forward, but also gives you some context and some maybe new ideas for how to frame where we are, what we need to do today, and where we're going in the new existence. So I truly hope that this was helpful for you. And if there's anything else that we can do as an organization to help you, please don't hesitate to share that with us. We do have a lot of resources currently, especially around COVID-19 and also addressing systemic racism and health disparities that have been found to be useful and effective. So please come hang out with us at the Barrel Institute, find your support, find your people, and share what you're doing as well. You all obviously have some really great things that you've already accomplished in terms of working with your patients and families and bringing them back to your organizations. So I would ask that if you have these pearls of wisdom or case studies to share with us, that you would not only come to get support, but also to provide support to those who are seeking some solutions. So with that, I will say thank you. And once again, I hope that this was helpful. I hope that you all stay well and continue to brainstorm ideas on today, tomorrow, and our future. Thank you all so much. I really appreciate having the opportunity to be here today.
Thank you, Tiffany. And I think that really helps set us off on a really empathetic tone and keep patients in the center of our discussions. And judging by the chat, people are now ready to dig into the nuts and bolts. So, and we will make sure to give you lots of time in the next few sessions to be able to do that, all while keeping that patient experience in our line of sight as well. So we are going to take a quick break first. We'll see you back here at 9:15. So use this break to stretch, get up, walk around, and come back nice and fresh. See you in 15 minutes.
Hello. Check 1, 2. Mic check.
There's no mic check.
I know. I'm just making. Well, you can see it's working.
No, but we're
We're hearing you. We're hearing you.
All right. Thank you.
Sure.
I thought we were gonna go.
Hi, you may have just joined us on a break. Can you hear me?
Yeah,
Sorry,
Lainey.
we were having trouble setting up the video, but now it looks like we got audio and video okay now.
Excellent.
Okay, great. Oh, hi, Mandek.
Hi.
We're just on a little break, so we'll come back to you in just a second. But thanks for joining.
I hope we can share the slides, because the problem we're having earlier is the minute we actually pull up the slides and background, it actually affects the video. Right?
If we can't figure it out, we have slides we can just show for you, and you can tell us how to proceed. So,
okay, thank you.
Yep.
And Nicolene, I think, is on. Nicolene, do you want to, because she's chatting me.
Yeah, I'm on.
Do you want to try, would you be able to kind of help them?
Yeah, what's the problem, Amanda?
Can we try to share the slides now, just so we can see if it?
Sure, go right ahead.
Okay.
Share. Host disabled participant screen sharing.
Oh, you have to make Jason the host, I think, Nicolene.
I don't know what the problem was. Okay, you're back at co-host, so you're able to share the screen now.
Okay.
Hi, Mandek.
Hi, how are you, Shelly?
I'm good. How are you?
Good. We're like trying to act like we're Zoom experts because we're
That's what all of us are doing.
And you know, I wonder, Mandek and Jason, can you try speaking again? Because I wonder if you're calling in on your computer, if you kind of chopped up for me.
Oh, see? Yeah. So we should probably call in through the phone. Let's do that.
And you know what? I was doing Altero staff webinars a couple weeks ago, and I had a lot of signal issues. So I don't know if it's the location where I'm at in my apartment that is an issue, that when we share the screen and then we go access a different app, that's where it seems to really get choppy.
So it might be best then if you call in, but you just to make sure that you turn off the computer audio and switch to the phone audio.
Okay. We'll call in. Do you want me to call in or your phone?
Hmm?
Do you want me to call in?
Yeah, we can use this.
Okay.
You actually sound okay right now. You did break up in the beginning, but right now I can hear you fine.
Yeah, it seems when we switch screens and we go to a different app, that's when it mostly gets choppy.
So audio switched to audio.
Go. You can hear us now, right?
Yeah, I can hear you. So Mandak, did you all click on the switch to phone audio? The little mute, unmute microphone icon at the bottom left of your computer. There's an option to, once you click on that, switch to phone audio. Is that what you did? Okay, great.
All right. We're going to get started in just a minute, right at 9:15. So if you're sitting at the computer and you're done your break, maybe you can turn your cameras back on so we can see your faces. Yay, people are turning them back on.
And just thinking about it, like if you're sitting in a meeting room, it's kind of easier to know who you're talking to because you can look at people's faces. If you're sitting on a Zoom and see a bunch of like blank screens with names on it, it just feels like you're talking to your wall.
It does.
So we'd love to see your faces. It would be really cool. And don't worry what you look like. It's okay. We all look a little weird on camera. I am getting older and it's always horrible to look at myself on camera because things are like in different places than they used to be. But still, here I am.
Before we launch, you know, one of the things we really hope happen today is that people hear things that you can do differently or that you want to do in your day-to-day job, but also that you can hear things that other folks do. And Peggy, do you want to show what we heard people might be able to do and some action items from our first presentation? And kind of talk us through what that is.
So as you guys are talking, I'm trying to pull just kind of one or two ideas and we'll fill them in with those ideas from the chat box as we go. But thinking about for different departments, what might be the things that you could take out of each of these presentations, kind of take back and think about what only somebody in your role may be able to do or what you could be the lead on. So again, we'll fill it out, but we love those chats because it just really works on sharing that great information.
Yeah, we love the chats, but we also saw on the chats, I saw like this desire to dig in and talk a little bit more. So the next three presentations we have are going to be really brief. They're kind of flybys. Our first is on chronic diseases, and Mandek and Jason from Terrace Health are going to talk about that for about 20 minutes, and then we're going to unmute our lines and be able to have a discussion and dig deep. So why don't you guys introduce yourselves, and then you can share your own screen and your own slides. Go ahead and take it away.
Thank you, Rebecca. Good morning, everyone. So I'm Mandek Aiden, and I currently work for Terrace Health. I focus on population health, which is really just using data to identify interventions for better health outcomes for our patients and better care at a lower cost. We're very happy to be here today and talk to you about our take really on how we helped our patients manage their chronic diseases. In this new landscape, it's challenging for everyone. Jason?
Good morning, everybody. Thank you for having me here. My name is Jason Pulowski. I'm really glad to be here today as the first and the only registered dietitian nutritionist with Teros. So I'm glad to talk a little bit about what we do and how we've worked our integrated model of healthcare and how we've tried to kind of wrap our arms around as a team model to some of these folks we're helping in these cohorts we're talking about today. And I do work at a variety of different Teros locations. So I kind of cover all over the Valley and available working closely with all the primary care providers at Teros.
All right, so we're going to share our screen. If we lose you, please, we apologize in advance.
And it looks like you may have turned your cameras off when you did that. So you're going to want to start your camera up and then hit that share screen thing.
Okay. Okay, start video.
There's the camera.
And share screen. Okay.
All right.
And it's like, okay. Presentation mode. Okay.
All right, so the topic for today's session is how can health centers manage their patients with chronic diseases in this new landscape? So the objectives for this portion of the workshop are to discuss barriers to care for patients with chronic diseases during COVID-19. And the second objective is to identify interventions that can be employed to manage patients with chronic diseases. Before we actually get into our lessons learned and share with you some of the barriers to care that we've experienced, we're going to try to frame the discussion really on this topic by drawing on our work and experiences as they relate to the Target BP project, which is a collaborative effort Teros Health had with AACHC, ABHS, and the American Heart Association to help our patients manage their hypertension. So to give you the proper context for the barriers and lessons we're about to share, I'll go over the population health profile for the patients that we targeted. As you can see here, those patients tended to have 2 to 4 visits with us per year. 30% interfaced with our behavioral health consultant or our registered dietitian. 7% reported a language barrier, 40% reported using tobacco, and about 30% also had a diabetes diagnosis. As the graph shows you, when it comes to BMI, 57% were in that obese category. So that really gave us a place to start and focus our pilot. So we first honed in on patients who have both hypertension and obesity. We use an integrated care team approach, and that really simply means that we really try in everything that we do, the care that we deliver, to wrap around the patient. As you can see here, there are many roles involved and many roles really surrounding that patient and really being involved in the care of that patient. I'd like to highlight a couple. The registered dietitian and the behavioral health consultant, for instance, are really about providing self-management tools to our patients, encouraging behavior modifications, and really encouraging the lifestyle changes that they need to make in order to manage their chronic disease. The CHWs, on the other hand, are really giving us that continuity in communication that we need in order to follow up on that patient and really outreach to that patient.
So thank you, Mandek, for giving us kind of a little bit of a bird's eye view of this whole project that we've been working on and how all these different providers kind of come together and we offer our different areas of expertise in terms of trying to, like Mandek said, wrap our arms around that patient and give the best care we can. However, as all you guys know, with 2020 and the pandemic we're in, we've all experienced a lot of changes and we kind of just have to make some adjustments. So one common barrier I found was that limited face-to-face interactions. So a lot of the clinicians are working from home, including myself. So this kind of really limits that face-to-face interaction and that interpersonal communication that we're used to. So I found that as a unique challenge or maybe a barrier to some folks that maybe just, had a harder time engaging. Maybe they had a harder time finding that motivation and just really building that rapport and connecting with that patient on just the phone. Where on the other hand, I did find that as an opportunity for some patients. There was that small group of patients I found that maybe I would not have connected face-to-face in clinic. Maybe they deal with social anxiety and they don't like to show up to clinic. So I found some folks that I was able to connect to on a more unique opportunity and connect with them on the phone, when some of them I might not have connected with in person as much. So it kind of, overall, I would say that limited face-to-face interaction was a barrier to most, but to some, it was an opportunity. Another barrier that I encountered was the limited access to self-monitoring equipment. We were fortunate enough to get a fair amount of the cups to give out. That did happen right as a lot of the clinicians were starting to work from home. So it was challenging to get all the patients that needed cups, to get them properly educated on protocol and get them the cups that they need to do that self-monitoring if they weren't coming into clinic. And health literacy was another common challenge or barrier that I had to face, that it really just kind of depends on where that patient starts with their initial baseline knowledge. And sometimes you have to spend a little bit more time working on those fundamentals with that person before you can really help them out with a more comprehensive diet, like the DASH diet, for example, that I would educate that person on maybe at a second or third visit. If that first visit, we might have to address some of those other challenges first. And then we look at the last point on there is the perceived severity of diagnosis. This was a lesson I learned this year as I worked with these different cohorts. I found that in general, when I educate people, we're talking about diabetes, they seem to really understand that threat to their health, and they grasp that a lot more. Maybe they've experienced their family that has dealt with some health consequences from diabetes. So I found that it was, in general, easier to motivate and connect and promote some healthy changes through the diabetes cohort. Whereas when I was working with folks, educating them on blood pressure, a lot of times I found they just didn't really perceive that threat to their health as they do more commonly with the diabetes. So that was another barrier I found to really connect with that person and give them the best care that they really deserved. A couple other barriers, of course, patient interest in the self-management tools. So sometimes this means that maybe the people that I feel I need to help the most might not want my help. So it really depends on where they're at and how ready they feel to make the changes we're talking about. Because lifestyle changes aren't always easy for us, but depends on where we're at in that continuum of change. Maybe if we're more pre-contemplative or contemplative, I might have a really hard time connecting with that patient and helping them see the value in these changes we're talking about. Whereas maybe I'm working with somebody that's more ready for these changes, they're in the action stages already changing, then I'm probably going to have more of an opportunity to really engage with that person and see some healthy changes and see them monitor and control their blood pressure more effectively. And inevitably, as you're all aware of, the financial concerns that has hit so many of Americans that, unfortunately, that will impact our job with how we deliver care to the folks we're trying to help. So that was a big lesson and a challenge where I found out that I really needed to kind of reconsider my approach with how I help these people at this challenging time. And I found that sometimes I needed to address some of their food insecurity issues was really needed to be addressed before I could even talk about that DASH diet. It didn't make sense to educate somebody on a DASH diet if they're too worried about paying their bills and they can't even get breakfast. Then I kind of got to start with that food security before I can educate them. So that's another barrier that we hopefully will keep working on moving forward.
So now let's talk about what worked for us. We've had quite a few lessons learned as part of our effort really to help our patients manage their chronic disease, and as Jason just mentioned, in a really uncertain time. So the first thing here is that when placing an outreach call, we learned that we need to focus on questions about the welfare of the patient first, before getting into the reason for the call or the medical reason that we wanted to discuss. And really simply doing that makes the patient more comfortable, much more likely to share and listen and really comply in the end and really partner with us on managing their condition. And this really ties back to what the previous speaker said when she mentioned that in order to increase patient experience, when it comes to patient experience, people really said in their feedback, I want to be addressed as a person and not as a disease. The other thing that we really did early on is that we collected feedback, the voice of the customer really, so in this case, the voice of the patient. And that really enabled us to ask our patients, this cohort that we were trying to really partner with, in this case with hypertension, it enabled us really to ask them what was important to them in managing their hypertension. So we created a survey. I think that we're going to share that template later on. And if it's not, then we're going to have our emails at the end. You're welcome to reach out to us. We'll be more than happy to share any tools that we developed. But what the survey really told us is that people cared first and foremost about weight loss. So that gave Jason and our behavioral health consultants an in to really start that conversation from a point of interest, right, to the patient. And the conversation, again, flows much more nicely. The third lesson learned here is that we intentionally had to flow our patient education through Jason, our registered dietitian, and our behavioral health consultant. Patients were much more likely to listen when it came from them than, for instance, when it came from our community health workers. So this education took the form of one-on-one phone consultations, Facebook Live sessions. We recently had two during National Community Health Center, one on diabetes and one on hypertension. And then we also made sure that we leveraged the classes that are offered in the community and that we give our patients options for self-management courses near their home. For instance, Esperanza is a local agency here that offers free courses on how to cook a meal, how to have a healthy meal. And really that class, it's a virtual class, it's a free class, also includes a grocery tour. Not quite sure how they're doing it nowadays, but they might still actually have that component in it, which is something that today we're not offering our patients. So it complements the education that Jason and our behavioral health consultant actually offer our patients. And then the last point we'd like to make on this slide is that we tried then and we continually try to identify partners that offer home testing kits or monitoring equipment for our patients. As Jason mentioned, we've had some struggles, as I'm sure you have too, lining up home test kits and really helping our patients continue to monitor their chronic condition from home. To that point, actually, we've had the American Heart Association gave us some blood pressure cuffs that we were able to distribute to our patients. But as I'm sure you know, we never have enough of any one resources. So we continuously try to look for people who are looking to donate home testing kits. Now, helping address social determinants of health, we talked about financial concerns. Lots and lots of our patients are burdened because they are not secure in their housing. They're not secure in their access to food. They can't afford to pay their rent or their utilities. So as much as possible, we have vetted and shared resources that will help them pay for rent and utilities. Because I'm sure, as you all know, this is not a new fact for any of you. Social determinants of health really affect the whole health of the person. But really what we've learned, especially in this COVID world, is that not addressing them actually makes starting that conversation about medical issues, hypertension in this case, as he said, is not perceived by many of our patients as something that is high on their priority list to manage. So if we don't start with their basic needs, we cannot be getting to a point where we can talk about their medical needs. We also reinforced medication adherence. And we did that through reviewing reports from health plans and making sure that we are following our patients in that they are filling their prescriptions on time. And if they're not, we had our CHWs actually reach out to them and ask questions and offer help. We also shared with them options on mail-in prescriptions, right? A lot of them are using the pharmacies within our clinics, and Genoa Pharmacy actually offers an option to have your prescription mailed in. So we made sure that they knew about those things, because transportation is also a problem for many of our patients. We can never overemphasize the use of technology. So we really try to maximize the technology that we have at our disposition. We use alert cohorts within our population health tool. We currently use Azara Drive. And we did that to address the chronic condition at each visit, right? Really having everybody on the same page, looking at the same thing, so that we do not miss the screening. We do not miss an opportunity to talk about the high blood pressure. We do not miss an opportunity to talk about the uncontrolled diabetes. Because as you know, increased compliance comes with increased provider involvement. And then the last point we'd like to make here is that it absolutely needs to be a priority for all. And you can only do that by making it an organizational strategic goal. For Teros Health, diabetes, managing uncontrolled diabetes was a strategic goal this year. And I'll tell you, doing that made everyone align to really achieving that goal and working towards that goal. Because a clinical priority may be a priority for the clinical team, but not necessarily for the administrative team, and vice versa. Whereas when it makes it to the strategic plan, it becomes a priority for all. This here is an example of actually the module that we use within Azara Drive to actually alert our providers and our care teams on what's missing and what's needed. So as you can see here, at a glance, they can see the diagnosis, the risk factors highlighted. They can see that this patient is part of a cohort, so it needs, blood pressure needs to be addressed right there. It says blood pressure out of range, so the provider, at a glance, can take action.
And just to kind of take a quick look at some ideas moving forward. So I spoke a little bit about some of the challenges of the research around hypertension. So one thing to further explore in the future is different ways that folks can standardize that self-monitoring of that blood pressure, making sure that there is that clinical accuracy and it's meeting coding requirements. And you know, a lot of folks are monitoring from home, so we need to make sure that we're doing it right and we're finding reliable data that is accurate. But also taking the screenings to the patient. I know we've talked about everything that's changed in 2020. Well, we need to adapt to the changing times, and maybe that means meeting the patient where they're at. Maybe that means having more drive-through screenings, and not just for COVID testing. Maybe we need to expand that to preventive screenings like blood pressure or other measures to consider. Also, increase patient engagement. As we spoke to the challenges there, you know, if there's not much patient buy-in and engagement, it's hard to help that individual. So that's often where we need to start, is with that patient engagement and build on that. And then naturally, we're able to help more people more effectively if we can work on that engagement. And of course, other ways to think about more engagement, we can think about how we can incentivize these healthy changes to make them a little bit more exciting or motivating. But also think about how we can work closer with local different agencies and different safety net providers as to how we can collaborate and solidify our efforts to make sure that we're really just giving the best care and help that we can. And thank you all.
Good.
Yeah, so now it's your turn. We shared what we learned. Hopefully you were able to pick up, you know, a tip or two. Or we'd like to pick up a tip or two from you guys. So we'd like to open up the discussion and really ask you, what has worked for you when it comes to helping your patients manage their chronic conditions? And really think about how else can we virtually conduct and support health monitoring when it comes to chronic diseases in a landscape that really does not allow for face-to-face visits.
Thank you. Yeah, so what has worked for you? And remember to unmute yourself to talk. And Jason and Mandek, if you want to stop sharing your screen so we can look at the Hollywood squares, that'd be great.
Okay.
I'm curious to hear from, I know that this is something that all of your health centers, work on in one way or another, but for those of you who don't have a Jason, who don't have a registered dietitian, how are you doing this differently? What other members of your care teams do you bring in for that patient engagement? And there's some things popping in chat, and I wonder if Adelante, if you could unmute yourself and tell us what, how those virtual Zoom visits are going.
Hi, I'm the one that put it in the chat, but I might have to call Shannon to do more talking on that topic because that's her pet project. But it took a lot of technology assistance to be able to set things up so that we could send the patients a Zoom link because we didn't really have that really set up. Working with our compliance team about whether or not we're talking about patients' health and there's issues with Zoom. But I think in the end, we worked out all those details. And what I hear from Shannon is it's well received. Shannon, are you there? Do you mind making a comment?
Sure, no problem. So one of the big things was that some of the patients we would send the Zoom link to after we had an email that we didn't want any HIPAA HIPAA information on. We had to work all those kinks out. But one of the things that we did is if a patient couldn't log into Zoom at home, then we would actually call them in for a visit, have them come in, and we do like a little tutorial with them. So we actually just started our first Spanish session of DPP yesterday, and we had 7 patients attend. So it is working for us so far. And the other session that we have going, the English session, is on its 5th week. And we've had a couple patients not attend, but throughout the few sessions, but we've been able to make it up with them at a different time via Zoom. So the patients seem to be working really well with it on their, a lot of them use their phones and a couple of them have laptops, so.
Does anybody like use Zoom as like a group visit yet? For obviously you can't do the same sort of group visit with exams, but in like kind of group peer support and counseling with a provider there to kind of guide things in the right direction?
We have not done group visits, but the DPP program are group classes. So we do have our certified life coaches that are leading those sessions. So that's as close as we've gotten.
And even a couple of the participants actually started a walking group out in Surprise. So they walk in the mornings like 3 or 4 days a week. So they did that on their own because they can chat with each other and decide if they want to share their information with each other on the chat boxes. So it's been successful so far.
And just to speak to that, at Teros, from what I understand, most of the counselors are offering the group counseling. I believe WebEx is the main platform that they use. And I've attempted to join as a guest speaker in a few different group sessions. And it's been difficult because I've had different video challenges where I was able to provide the audio, but was not able to provide the video. So I think it just kind of speaks to some of the other challenges we're all facing with adjusting to technology changes.
Yeah, Dr. Sultani, you brought up in the chat another challenge around getting consent. Do you want to talk a little bit about that and how maybe you down in El Rio you've thought about making that process more efficient?
Yeah, I mean, I think just similar to the points made with this group, it's getting patients connected with resources that you could never connect them with before because, they did not perceive the level of threats or they would not make it to their nutrition visits or make time for their BHC visits. And now that we can bring those visits into people's home, we have an opportunity to overcome some of those barriers. But you have to incorporate the the amount of calls that you make before you can reach a patient, and also, need to make sure that they consent for that telephonic or virtual visit. But once that happens, at least now in the public health emergency, Access is compensating telephonic and video visits similar in PPS rate to an in-person visit. So now's a really great time to try that technology and try that workflow and see how to get that to work the smoothest and get your best hit rate in terms of visits.
Has anyone, it sounded like you've been able to get your hands on some blood pressure cuffs to send to patients' home. Has anyone else found success? Where can we, I think Mandek would probably take all the ones that you're not using, but.
Yes, I would. Thank you, Rebecca.
Is anyone else trying that out?
We definitely here at Adelante, we created a standing order so that support staff would be able to order blood pressure cuffs and blood sugar monitoring devices for patients in advance of their telehealth visits. So they would have some readings to talk to their provider about before they came in. I think that was successful. Still a little challenge with our patients being able to afford them when there are, had different programs. But as everyone here on the QI side at least knows, since right now we're still not able to include patients' self-monitoring numbers as their UDS. It still hasn't really, it's helped with clinical decision-making for our providers, but you don't see that in our reporting.
Yeah, same here. We take them and we input them in the chart, but we're not really using them for reporting. So it's really just to gauge and really keep that conversation going with the patient.
Right. Do they have them that automatically populate into the ER, and then would that count for the UDS, or any self-monitoring won't be able to be counted?
No, I think there's pretty strict requirements around that.
Yeah, you can get devices that integrate with your EHR. There is certain devices that are allowed to be used, but they're not easy to come by. Having the insurance plans pay for them is something that we haven't worked out all the kinks for. So,
yeah, if you do work out all the kinks, please let me know. You'll save me lots of work.
Yes, it will be shared broadly if we figure anything out.
Yes.
Dr. Saltani's chatting in. They're $33 a person, so I think she's looked into it as well. I never want to read all the chats because I know some people are having their own, conference in the chat box. But Yoendri is saying that for their patients, the access to technology has been a challenge. Have other people? I'm seeing quite a few heads nod. So.
Yes.
It's a challenge with our patient population. Circle This City is the healthcare for the homeless provider here in Maricopa County. And so we talked about self-monitoring and cuffs and looking at those for our patients, but it really just isn't a good fit. Like you said, the data doesn't count anyways, plus just not a good resource for our patients. So we kind of took it old school around chronic disease and have just been focusing more on trying to get information into our patients' hands each and every time that we see them. We partnered with the American Heart Association in coming up with some more resources that are kind of specific for our population. So business card size things, pouches that waterproof pouches they can carry their medication in. So we just had to get really creative around our patient population and how we can support them in this time with their chronic disease, and technology isn't the answer for us.
Yeah, thank you for that. Yeah. So thank you guys both for that. Peggy, will you show what we've heard for our kind of key action items that we heard for each department? One of the things that was interesting, this idea of how, we need to prioritize our UDS measures. So if it doesn't count, are there other ways? How do you put more action items in that C-suite box to be able to get that priorities? And I think that what Teros did around integrating into the strategic plan some efforts on that is really great. And Peggy, you might need to make that a little bit bigger so that we can read it. And we'll give you a second to kind of scan through that.
So this is your opportunity to see how my brain works.
Yeah.
Things into boxes. So you can giggle if you want, but you know.
I have to.
And I'll fill in those boxes for you. We'll share this stuff back with y'all.
Yeah, we will share. But if you heard, if you heard something or thought something either by participating in the chat or through the discussion or the presentation, and you are a member of the billing team or a member of the informatics team, and you're thinking, oh, this is something I really need to go back and do after hearing that discussion, please chat that in, because we can add that to the sheet. And then when it goes back to your folks, the people in the QI department can have a little bit more tailored asks for their colleagues to try and improve these patient outcomes. So, all right. And Peggy, you want to stop sharing now? We're going to introduce now Dr. Darlene Melk, and she's going to turn her camera back on. There you are. Why don't you go ahead and introduce yourself and then just take it away. And remember to turn your cameras on if you're, even when you're just sitting there. So Dr. Melk knows you're staring at her.
That's always. Good morning, everyone. Thank you for inviting me to present today. Not in the circumstances that I would like, obviously. I think we all are very social beings and would prefer to be in a room together, but I am going to take you through a little story here at our health center on how we kind of continued our pediatric services through the pandemic. So I am a pediatrician by training, and I've been at Chiricahua Community Health Centers for 10 years. And just stepped into the role of CMO last month in July. And so with that, I'm going to go ahead and share my screen. Let's see. Make sure. All right. So our service area, and let me just do a quick check. You guys are seeing the full screen, right, Rebecca? Okay.
Yep, we see it.
Not the preview.
Little yellow box right over your house, I think.
That's perfect. Okay, so this is our service area at Chiricahua. We call it our square. We're southeast corner of the state, and we border about 100 miles of U.S.-Mexico border. I truly believe in this. As a pediatrician, there is no way in the world we can raise children to be healthy adults without a team. And the pandemic, I think, really brought this to light. So this little being came and rocked all of our world last year in December, as we all know the story. So right here in Arizona and in our health center, when this executive order came out on March 11th and then March 15th and all the schools were closed, we recognized quickly a couple of things. Number one, pediatrics kind of relies on sick children. That's our book of business, honestly. And overnight, we saw that our health center productivity was going to be at risk, huge risk. And so quickly needed to assemble a team to decide what we were going to do. And the other thing that we recognized is that the pandemic wasn't slowing children from being born, newborns that needed to have, bilirubin checks, weight checks, very, very important developmental screenings and immunizations. And so we pulled one of our pediatric nurse practitioners who had some background in public health to be our COVID task force lead. Her name is Kayla Percy, and she's just kind of been the hero through this time. And immediately started looking at CDC, AAP, Arizona Department of Health, and our Cochise County Health Department for guidance, and came up with our initial response, which was, we're going to continue, we're keeping our spaces open, but we will designate what we called well areas versus acute care areas. We knew that we needed to have some sort of greeting or screening that takes place at each site, that we were going to start offering telehealth as quickly as possible for acute visits to allow us to do some screening. And then probably most important, I felt, is that we decided to continue well baby care in person for children under 5 for obvious reasons, and mostly around immunizations, important immunizations. We didn't want to see childhood illnesses, preventable childhood illnesses coming back to life. So just a few pictures. I think pictures are always kind of nice to look at. This is our Pediatric Center of Excellence in Douglas, which is a border. I'm actually standing in Douglas. I live here right a few blocks from Mexico, which we designate this site because it has an on-site lab. It was just made sense to do our acute care here. Well, down the street, and this was a center we opened in 2018, actually because we were out of space in our pediatric center, and we decided to do something a little different. So down the street, we actually have a center called the Early Childhood Center of Excellence that already was focused on young children and preventive care for children with chronic conditions. And so this became our well baby care site. And then we were fortunate that in our Sierra Vista, which is our largest operation in pediatrics in Chiricahua, that we had actually 2 suites. Literally in January of this year, we had just opened the 2nd suite and it was perfect. So we were able to designate that as the acute suite, and then we had an opposite area for well baby care. And then some of the sites that were family health centers that weren't set up quite as conveniently, what we did is we brought in our mobiles, and we parked our mobiles outside of the office so that we could designate that for well care, and the acute care took place inside the building. So that was in Benson, and this last one was in Bisbee. And those 4 sites where we did most of our pediatric care. So obviously, I'm sure everyone faced this, pulling out your N95 from residency, or just like trying to remember what to do to don and doff. I mean, there was a lot of training that had to go on and workflows. And so I have to say, Kayla Percy was amazing at this. She put together a lot of visuals, video conferences, you name it, just to get all of the staff trained up on protocols, on screening, and the importance of it. And I have to say, it was very well received. I mean, we met daily for several weeks, every single day. So concurrently, because of this, frightening sort of reality that patient care, like the patients just stopped coming in. I mean, they were following the governor's orders. Everyone was staying home. So we thought, we have to do this to stay alive, quite frankly, and also to stay connected to our patients. And so this was another pediatric nurse practitioner that we pulled from clinical care full-time to focus on our telehealth efforts. And Devin Thurber, who had some experience in telehealth with pediatric endocrinology for our patients with type 1 diabetes, she rose to the occasion because basically of this experience was able to help us roll out telehealth for our providers. So PR, boy, is that everything. Lots of Facebook posts. Our PR, public relations specialist, she was putting things out on Instagram and Facebook, and everywhere that we could. We tried to reach out to patients, sent them an automated text message to let them know we were offering this service. And then we also put together what we call the Scheduling Command Center, where we did met weekly to talk about strategies to bring our patients in, and specifically around children. We used Azara to pull data on risk registries. So we kind of looked at the children that had higher risk, and also adults. This was happening in both areas, but mostly pediatrics, quite honestly. And we set some goals of how many outreach calls we wanted to do each day. And we basically said all hands on deck, meaning not just the MA or the PSR, the front desk person, but providers were actually reaching out to their patients to call them and to say, hey, we're here. Is there anything that we can do to help you? Or actually scheduling follow-up on some of their chronic conditions, so they knew that they could stay connected. So again, you know, posting on the social media that we were doing, taking all of these measures to make sure that families felt safe to come in, and that we had these designated well areas or well spaces, I think was part of the strategy that was successful. And then we eventually, on May 4th, started to actually offer well visits by telehealth. And believe me, this was not an easy sell for our pediatricians. They all just thought this was the most crazy idea on the planet. How can you do a well visit without a height and a weight and actually examining the child? And so I actually brought in a speaker, a colleague of mine from Phoenix Children's Hospital at a pediatric conference to talk about how they were already doing well visits for via virtual care and some of the challenges, but also some opportunities with this form of care. And so finally, we started to have the buy-in, and it took some of our resistors who actually really started to like this form of care that I think helped move it forward. And then June 1st, we started to actually reach out to children, you know, in any age that was due for any immunizations, or if children were coming in for sports physicals. And so we started to reinstate some of our in-person pediatric well care. And then the other area is any child without any access to video technology, or quite frankly, if the parents really had a strong preference to in-person, we started to do this in June. So, you know, in preparing for this talk today, it really made me kind of realize and reflect on how much of a team effort this really has been and continues to be every single day. So as I mentioned, we had the COVID task force lead and the telehealth lead, two very strong clinicians that, you know, honestly, without their help and then to get clinician buy-in, I think was really important to be able to pull this off. The public relations specialist, she was instrumental in kind of keeping our posts up to date, and families would go to that, go to Facebook to kind of see what was going on at Chiricahua, or continue to do so for blitz testing and things like that. The clinic managers, holy cow, these individuals are just really were the ones to enforce and make sure that the workflows and the screening protocols and the well versus the acute care, everything was being taken care of. So again, very frequent meetings with them, especially in the beginning, and these continue to happen at least on a weekly basis. Our patient access manager, who basically oversees the call center, was instrumental in understanding scheduling protocols and making sure that they offered families the visits in the correct spaces and scheduled them in the right place with the right provider. I mean, there was just so much detail involved in this. Medical assistants, I mean, we all know we couldn't do our work without our medical assistants, but boy, did they have to rapidly adjust to rooming patients virtually and learning how to do this and how to schedule them for labs and, you know, honestly, continuing to do screenings that they would have normally done in person. So really adjusting to this workflow is incredible. Our patient service representatives who are in the front desk, again, they were instrumental in helping check in the patients. This is how we check in our patients virtually, and then just making sure that patients were checked out and got their immunizations if they needed to come back for those appointments. Those individuals were very important. Environmental services, as you know, this virus, you know, obviously lives on surfaces, and we needed to have our spaces cleaned, and so we enrolled or asked them to increase the amount of cleaning that they were doing so that our lobbies and spaces are cleaned every hour, and that we could post this to ensure that families felt safe coming in. Central supply, of course, one of the big things was that we do not allow anyone in the clinic without a mask, and so we have to make sure we have enough supplies. And so central supply has been huge and instrumental in ensuring that we had enough supply to make our spaces clean and safe. And then I also included here the quality team, which includes our nurses. Our nurses have been reaching out to the young. We are part of a grant through First Things First through the state, and they reach out to their families every 3 months to ensure that they're following immunization schedules, that they're coming in for needed well visits. And the quality team was instrumental in pulling AZARA reports to give to all of the patient care teams. So in the end, what was remarkable is in reflecting over the last year, and this is data that I just pulled, I think Monday, from AZARA, and this is a rolling year, so this is actually a comparison of August of 2019 to now. Our immunization rates in 2-year-olds, this is 2-year-olds, is up 9%. And so to be quite honest, I was just hoping that we wouldn't go down. But this was a really great thing to see. And I honestly believe, I know that it wouldn't be possible if we hadn't all kind of pitched in as a team and had all of those departments, you know, kind of helping us reach out to the families, ensure that our spaces were safe for them to come into, because unfortunately you can't do a vaccine virtually, right? So we had to do this, and so we needed to ensure that families felt safe to come to us and had that trust. And in the end, it seems to have helped, to have worked. And so with that, I'm gonna actually stop sharing. Kind of went quickly, but
well, everyone is jealous of you.
Oh.
I think some people like went up 9%. So and people are also asking, who did you get to speak to your docs? It sounds like your pediatric team. It seems like a lot of folks are also experiencing resistance to do televisits.
Okay.
Who was the speaker? They want to know.
Yeah, I'll sell her for you, and no, I'm just kidding. Sarah Beaumont from Phoenix Children's. She was one of my co-residents, my senior resident when I was there, and we worked together a lot because of our mobile work. But yeah, she was, Phoenix Children's was doing these telehealth well visits before us, and you know, all our pediatric providers kind of looked to Phoenix Children's as like the standard, right? So I think that was part of the buy-in is, you know, and honestly, I was on an AAP call just prior to this, and, you know, recognizing that one of the scary statistics through this pandemic is that reports to DCS are down. And why is that? Because children are not in school, and the majority of those calls come from teachers. So there was a pediatrician on an AAP call saying, if you are not checking in with your patients, who's going to? And these children could be in very bad situations. And so, not to take a negative stance to it, but I basically kind of said, you know, call to action, guys. We need to step up here. I know it's not perfect, but we've got to reach out to our patients and at least have that conversation, let them know we're here. And I think that was part of our success too, is just, you know, really getting the pediatricians to understand the importance of doing that and connecting with families. But yeah, and I saw somebody ask if I'd be willing to share workflows, and I absolutely would. I have no problem sharing whatever workflows you're interested in, telehealth or the COVID workflows. Yeah, we posted everything on our employee intranet. We basically have all our workflows there, so any new employee, any new hire can reference them. And so it's kind of ongoing efforts for sure.
Great. There is a way, which I think a lot of people have figured out in this Zoom, if you click in the chat box on that file icon, you can share your workflows as well. Maybe in the break, Dr. Milk can try and dig through her files and find them and just post them now so that we'll have them and you don't forget when you go back to work.
That's right. No, that's a great suggestion.
Have any other health centers, have you looked at your immunization rates, your babies or your teens? What are they looking like?
Oh, so you're saying that they're going down. Well, I'm jealous of United. Is United on the call? Anyone from United? I don't know if you noticed in my slide, but at the bottom on the right-hand side, it's got all the health centers listed out there, and United is the top. So is anybody here from United? I'd love to hear from them. No? Anyway, they've always done pretty well at this measure.
So it looks like one person's, they're sad
low
in the chat box, so some are getting lower. What are you, how are you focusing on that? Because that's an important measure, but that's like a really important thing for the communities too. So
yeah.
What are your ideas? What are you guys doing to get kids back in?
Yeah, I mean, like I said, I think it's honestly just for, first of all, getting us, the organization and the staff to understand the importance of bringing them in. And to be honest, that didn't seem too difficult to sell as far as to the staff, you know, because we do understand that there's, you know, we don't want like suddenly a pertussis outbreak or something to take a child's life for that, right? You know, these immunizations are incredibly important. And then just routine well baby care and that critical, I mentioned we have an early childhood center of excellence. So I have to say, our organization already is very focused on early childhood and how crucial the brain is and what's happening. And so I think our staff was sort of primed because of that they understood and had really, you know, sort of feel passionate about this. So then getting that message out to the public, and you try multiple ways. I mean, like I mentioned, Facebook and all of that, but in our communities, so much of it is word of mouth, and patients that will come in and have a positive experience. You know, they're talking to their friends or they're putting it on Facebook, and so that I think was also very helpful. Is you know, the patients themselves sort of helping promote the message. But yeah, you know, honestly, I shared this slide with our quality council actually yesterday morning, and and our CEO Jonathan, he said, well, why do you think this is? What is the actual, you know, how the cause and effect? And you know, it's really hard to pin down because it wasn't like we did a PDSA where it was all focused, okay, we're going to do this one intervention and then we're going to measure the outcome. It was like, let's do everything at the same time and let's, you know, just try our best. And it's hard to kind of pinpoint. I mean, in my opinion, I think it was the aggressive outreach like that we did. I mean, our MAs were making 40, 50 calls a day to call these patients. So, I mean, we're not talking just, you know, soft kind of efforts. It was intense. We gave them goals. We want to schedule 10 patients a day, you know, just get out there, call the families. And so to me, that was one of the biggest things. But,
Anyone else have some thoughts on well care during this time?
I'm reading somebody, that they've started doing well visits all ages. Is this Adelante, right, Sue?
Yeah, that's me.
yeah, okay, cool. And so now you flooded.
Flooded. Yes, we were getting a lot of well visits again, but there was a couple months in there where we were just seeing less than 5. So we have a lot of catch up to do now. But even with seeing the lesson, we never stopped seeing less than 5 in the office, and we had special hours and, you know, all those things. But our immunization rates still went down because when we would outreach to patients, they were not happy that the only thing we were offering them was an in-person visit. But I don't know how many pediatric department meetings we had on this topic, but they were not budging on doing well visits. They thought it was terrible care. It was better to wait than to do it like that. And I just couldn't. And I'm a family doc, right? So it was really hard to get their buy-in, and Rob's a family doc too. The two of us were big advocates, but our pediatricians, we couldn't get there. So I am absolutely going to knock on your door for your contact and see if we can get your your person, or maybe even you, since you guys are doing it now, if you're willing to come in and talk to our pediatric group, because there is very much more that we can do here to get their buy-in.
Absolutely. Absolutely.
How's the, when you
I'd
do
love
a
to.
virtual visit, when you do a virtual well check and you code and bill for that, I'm wondering how is that paid appropriately? And there was a question in the chat about billing too. And then also when you bring them back in for the shot only visit, how is that getting paid?
Yeah. So no, I mean, obviously we had to do our homework. If we were going to roll this out, we wanted to make sure we were getting compensated and paid for. And so, yes, we bill the same code. The physical exam, I mean, we do not do these by telephone. I mean, some acute visits, if the patient can get on their video, we convert to a telephone visit, right? And for the time being, Medicaid is paying for these. But for a well visit, really, we don't do them unless they can get on a video, so that we can at least visualize the child. I get them to stand up and run across the room and like do jumping jacks, and you know what I mean? Like I'm kind of at least trying to do my assessment that way. And then what we've done in our workflow is if they are due for an immunization or a lab, so we bill that visit. And then if the provider identifies anything during that visit, or the mom says like, oh, you know, he's been acting funny, he looks like he's skinny, whatever, then we would schedule a follow-up as an acute on that concern, and then do a full exam and everything else, the immunizations, whatever was due. But if everything was fine and normal, and this is most often the case, but they're just due for vaccines, we actually are scheduling our patients for vaccines in labs to socially distance them so they don't all bottleneck and show up at the same time. And the other reason why we schedule them is if they're already there, the MA is grabbing a set of vitals at the same time. And so depending on insurance, like we're not always billing for that MA visit. So if like it's a VFC vaccine patient with Medicaid, they're not getting billed at that point, right? So so that's kind of been our workflow for those kind of cases. And yeah, it's not ideal. None of us like this, but it's our reality. And I think you just have to like warp your brain around it and say, this is it's better than no care. Like it's better than no care at all. I'm at least talking about their diet, like their behavior. I mean, so much of a well visit is the discussion. And one thing that's unique about Chiricahua, it's one of my recruiting hooks, but and we've been able to hang on to it for this long, and I hope we continue, is we give our pediatricians and our pediatric providers 30 minutes for well visit appointments, which is kind of unheard of. But that has been our standard for 10 years since I've been here. We've never let it go. And why? It's because we put so much value in that well visit. That well visit, we want it to be comprehensive and, you know, discuss all of the concerns. And I think, you know, I really loved Tiffany's talk in the beginning. It was wonderful on connecting with your patients. And so I want time to talk about dance class and their dog. And I mean, connecting with our patients, I think is the crux of what we do. And in pediatrics, it's following them through their life. And, you know, I think that has also in COVID's time, like helped us, because when we did kind of reinstate in-person visits, there's not like a bunch of kids in the lobby. We're able to get them back into the room, right? Because they're spaced a little bit more in our schedules. So that has been helpful, I think.
There's a chat in here from NACA and Flagstaff. They just started seeing patients face to face again. How does that workflow look really different when you start bringing them back in? Is there anything that you want to say? Don't forget this. Just start back up.
So I think honestly, it's just been, you know, acute care, like I said in the chat, and then everybody has been completely covered in PPE. One of our providers isn't comfortable doing the in-person. So of our 3 providers, only 2 of them are doing that work. Everybody who comes into the building is screened. Our staff, for the most part, is remote, although people are coming in part-time. And we're looking at getting back into sort of having people in the office after Labor Day, but we are doing screening with the questionnaire and oximeter readings and temperature checks. So we're being very, very, very careful. But the Navajo Nation, which is right next to us, was hit really hard, as everybody knows. And that really impacted us at NACA, considering about 55 or 60% of our patients are Native American, and many of those either live on the reservation or travel back and forth very frequently. So with President Nez taking all of the precautions that he did on the reservation, we took that to heart, and we're super cautious here at NACA as well.
Mm-hmm. Yeah, we've been kind of giving providers from, starting maybe in early April, we have providers on sort of flexed or, kind of staggered schedules, I guess is the word. And so we always want to maintain a minimum of maybe 1 to 2 providers in the building every day, but then we also give them like a whole day remote. So that day it's 100% telehealth, but when they're in the building, it's honestly a blend. It's either in person versus video. So I do it myself. Like I'll be sitting here doing a video call with a patient, and then I'm running back to the clinic to see a live patient in person. And so it's been kind of a hybrid schedule. And then, yeah, I mean, my words of advice, I'm sure everybody, screening, and we've had to, even in some sites, this has been a really tough thing because you have a staff person sitting there like the whole day when normally they're on the floor rooming patients. And so it had led to some staffing challenges. And so in some smaller places, and I'm not crazy about this, but we went to like a doorbell system. So like when somebody shows up, they actually like knock or they do the doorbell, and then a staff member just runs out to do the screening. And we do the questions, we do the temperature, we make sure they have a mask on, all of that. And so it kind of makes, controls a little bit the flow of traffic into the clinic. But yeah, we do the same screening of our staff and all of those measures. It's not perfect, but I mean, I think we always say like your chances of getting COVID at the clinic are lower than if you go to the grocery store. So, so I think we're doing much better than the grocery store. And families, I think, notice that. So
great. Well, we're going to move on to our next speaker. Thank you so much. I want to make sure people know that there's El Rio, Heidi from El Rio is saying that they're already doing drive-through immunizations. And if you have anything that you can post, please post those things, because if a health center is not already doing it, you're probably thinking about whether to do it, at least for mass flu clinics, right, this year. So please post whatever resources that you have, and some concerns about well visits. This is back to school time. We should have had a big jump. And maybe something that you might not know is that the state is still requiring immunizations for school entry this year, even if that school is only virtual. So I don't know if that's something you want to make sure that your outreach team knows about, but those parents may get a nastygram from the school nurse, around the time that immunization data reports due. So, so you might want to just reach out to those too. And Dr. Cruz is also posting in here that process for DT immunizations. I assume you're talking about the 11-year-olds, or?
Sorry, I just took a bite of my sandwich.
Oh.
That's why my camera's off, by the way. Yeah, we are actually talking about drive-through immunizations for flu shots, but also for the kids going back to school. We, like I said, haven't really had patients coming into the office, and we are actually, for patients that are going to start coming in, we're giving them the option of either in-person or telehealth. So the drive-through clinic, immunization clinic would be really, really interesting to see what folks are doing and to appreciate what is working. We are in we're in a strip mall. So we're not a standalone. We don't have our own parking lot. Our parking lot, there's cross traffic with grocery store and other businesses in the area. So I'm not sure operationally what that looks like. It's my job to sort of make it happen and have it have it be successful. So I am curious to hear what other folks are doing.
So if you're interested in jumping on a call or something, chat in your name if you want to talk about that, and we will circle back with you. I'm actually working on that on another project too. So between AACHC and the Vaccine Coalition, we'll figure out a way to get people together and just talk about it. So there's lots of opportunities there soon to talk about it. So I want to introduce Dr. Soltani from El Rio. Why don't you tell us a little bit about yourself and take it away. We're going to talk about diabetes.
Sorry, I was busy taking down that link and I forgot what I was doing. Okay, so thank you so much for inviting me. This has been such a stimulating morning, and I'm excited to see what comments and suggestions you guys have about this idea. So we're, as healthcare providers, all very aware of the misery that COVID has wrought in our communities, and at the risk of sounding tone deaf, I also want to suggest that these are opportunities to think also about ways that we could tackle our longstanding problems or longstanding challenges in a different way. And I think diabetes or uncontrolled diabetes is certainly in that realm. And when I say uncontrolled diabetes, I'll also use the word A1C greater than 9 kind of interchangeably. So I'm a primary care doc. I've been at El Rio for about 20 years, almost 20 years now. And I also work with Heidi Kurgat, who's contributed a lot to the conversation this morning, who's our quality manager, quality project manager. So I also thank her for her input. So I think as our patients and communities have hunkered down, it's really important to point out, and as you all have today, that the diseases that we've always cared for, the chronic diseases, take as great of a toll in our communities as COVID has. And so, this slide speaks to that as well, that part of the mortality and morbidity that we've seen in this era comes from those chronic diseases far, beyond the pandemic itself. This was a research letter that came out in JAMA earlier this month, and it shows that, again, the chronic diseases that lead to the heart disease and stroke are major contributors to that excess mortality. And that upper right-hand corner is the diabetes that we're going to talk about in a little bit. So I'm sorry about that. Part of what we've talked about is that our patients are no longer calling in or thinking to see us for these conditions, and that may be the case even prior to the pandemic. But we've used this opportunity to reach out to patients in a way that we may not have before. And so we did what many of you did, basically start calling out to those patients and saying, number one, we're here for you, but number two, don't forget about those chronic diseases. Here are some ways that we can take care of you. So in order to do that effectively, we tried to identify our population at risk, and we use a population health program called Relevant. And so that, I think, probably similar to Azara, it allows us to identify specific patient populations at risk, and we can identify them by the clinic that they attend and also by the provider. And that is very actionable data because it tells us who exactly those patients are, and also gives us their contact information directly from that population health tool. So we wanted to do specific outreach around diabetes, as it's a major risk factor for COVID, poor outcomes, and other poor outcomes, as we've sort of talked about. And what's interesting when you look at a slide like this, these are all clinics within our healthcare center. But you can see that this quality metric and other quality metrics, even within our center, we see a large variance in how successful the patients are at those sites. And that's a lot of factors go into that. It's the specific patient characteristics at that site, but also idiosyncratic things about that site in terms of how busy those providers are, how much outreach that they're doing at a provider level. So we had the idea that we would do a centralized outreach. And partly that was initially enabled by the fact that, the phones went quiet. So we had a group of people who are used to interacting with patients our patient communications group, who basically, had some free time at that point. And so we pulled out our list of diabetic patients and we asked them to call out to those patients. So that was how the idea of a centralized outreach kind of was born. So we chose those patients that had not been seen within the last few months, who had an A1C greater than, oh, sorry, I'm in somebody else's office right now. And so we gave them that list, and we came up with a script that they would use and kind of an SOP that they would use. Okay, so some of that scripting, because again, these are people who really may not have medical healthcare expertise on their own. So we gave a script so that they would have kind of a sort of standard way that they would be calling to patients, and yet make it kind of a personalized message, connecting the patient with somebody that they're used to, their physician or their team. So that script looked like, hi, I'm so-and-so, I'm calling from El Rio. Dr. Sultani is worried that your last A1C showed that your diabetes was not under good control. What day works best for you to have that follow-up appointment with her? And that was their chance then also to sell the idea of telehealth. So they would say, we have a way that we can do either a virtual or telephonic visit for you, kind of talk them through that, and then also effectively give that message in the community that we're here, we want to see them, and we have these other ways to see them. Part of that scripting said, have those medication bottles and glucometer ready to discuss for your appointment. And then the last part of that was, can you walk in a few days prior to the visit to get your diabetes lab test so that it's ready for the visit? And essentially with this scripting, we wanted to create an experience for patients and for providers that essentially kind of triangulated the visit, right? So for the first time, maybe in a long time, as a provider, you would see a patient who had their medication bottles, their glucometer, and had an A1C done within a few days prior to that visit. It made those visits much more actionable than we might normally have experienced. So we did this pilot with two different groups of outreach workers. So like I said at the beginning, initially we did this with the patient communications staff, and we gave them that policy or that workflow and the scripting, and for 12 days they called almost 1,000 patients. And this is sort of the outcome of their calls, because we're always interested to see what is the impact of the outreach that we're doing. Is it having the impact that we want for the amount of resources that we're using? So I thought, it's pretty amazing that they called almost 1,000 patients. And in that bottom right corner, it shows that about 30% of the time they were able to create that triangulated visit. So meaning they were able to schedule the visit and get the A1C ordered prior to that visit. So that's interesting. Now, what happened to the rest? So if you combine the 37% where they left the message and the 19% that the patient declined, at least it was an opportunity for the patients to hear, number one, we're here, we're open for business, we want to see them. And number two, that there's somebody that is concerned about the level of their disease control. So similar to hypertension, sometimes it's hard to convince patients that their diabetes is important, especially if they're not yet symptomatic from it. So that is an effective lesson or message that might change health behavior in the future, which is a good outcome. In 16%, the patient, either there was no answer after several attempts or the phone was disconnected, and that might give you an idea of what percentage of your patients may no longer be your patients. They no longer live in the area, or something else has happened. And then also really interesting is that 19% of patients who decline the visit, and some of that is that it's just an opportunity, again, for us to educate patients. So they decline, they say, okay, well, I don't have insurance anymore. Oh, well, it's an opportunity for us to say, you don't need insurance to come see us here. Oh, I don't have transportation. Okay, well, that's an opportunity for us to say, did you know we have a van that could come out and get you? Or I don't feel safe coming into clinic. Well, we have these telehealth services. So it's an opportunity, even as patients are declining, for us to be able to deliver an effective message that might have a health impact for them. After a while, our PC staff needed to go back to answering the phones. So we looked for another outreach group. And we have groups of MAs that are kind of in training as they start with us. And so they get a few weeks of training time. So we incorporated this outreach campaign into their training time. So in this case, they had 5 days and they contacted around 350 patients, and it resulted in that bottom right corner, you'll see it resulted in visits with an A1C about 41% of the time. So they had fewer people declining the visit, and you might say to yourself, that makes sense because these are medically trained people, and so they may be more effective at sort of making the medical case for patients to come in. So that was an interesting lesson for us. So I just want to stop here for just a second because the next couple of slides are a little bit different in content to see, what kinds of outreach are other centers doing. Makes sense to try to order that A1C ahead of time. Would you have the staff to be able to do that? We did that under a standing order. So essentially, once the patient agreed to the visit, if it was the patient communications person who was scheduling that, they don't have medical training or licenses to be able to order the lab. So then it would go to an MA that was working with them to enter the lab. But otherwise, it's a standing order for the MAs to be able to order the A1C. So it's extra steps in the workflow, but I'm just curious if people feel like that's useful to do. It's sort of worth the investment in doing that. I don't know if people want to unmute or if they just want to.
Yeah, unmute yourselves. What do you think?
And then the other thing, as part of scheduling that visit, we talked about having that visit be a different kind of experience for providers and patients, where you've sort of triangulated everything you need for the most useful visit possible. And, what other data would you want? We looked at getting the NPR medication possession rate, so how often are patients filling their medications? Are they filling them in time? And we did initially try to incorporate some of that. It was just a very data intensive, and sometimes providers are really overwhelmed when they're seeing lots of patients to try to, pull that data from somewhere else. So anyways, just some thoughts a little bit about that.
Yeah.
This is again Sue from Adelante. I can tell you that we've had a lot of conversations about how to more effectively pair MA type of standing orders and vitals and A1Cs and such with telehealth in a more effective way. We keep spinning around the issue that we don't really have staff necessarily to staff a separate MA visit schedule for those types of things. And the current staff that we have are busy rooming and discharging and doing whatever they need to do for their providers. And so, we've kind of talked about it in different ways and kind of revamping how we schedule MA visits in general. But I think we're still having a little bit of a disconnect about what makes sense clinically and what makes sense operationally. So we've probably had 5 meetings on the topic. Every couple weeks we get together and then we don't come to a conclusion. So, that's our cycle that we're spinning in right now.
Thank you so much for that, because I think that's exactly the issue. So when we talk about doing outreach to patients, that's really more in the population health realm. And unfortunately, our healthcare system is funded primarily still on a factory base, right? So it's just you get paid for the patients that come in front of you and you just wait for them to passively come in. And sometimes we're more than busy enough to do that, to not have to think about how to do some of these more difficult things. But I think those of us that are in community healthcare really are sold on the importance of doing the only way to do population health, the only way to bring up the health of the population around you is to outreach to patients, because those patients are the very patients who are going to have the worst outcomes. They have many, many barriers to calling us to pick up the phone in the morning and call for a preventive visit or call for a diabetes visit. So the only way we're going to do well by those people is to do active outreach. So that's sort of the medical and the moral and the social justice case for doing that outreach. And I don't think I need to convince any of you of that. Now the problem is how to make that business case. Since our healthcare system is not yet funded on a population health model, although value-based care does start to help us with that, what are the ways that we can fund, the MA is not the most expensive person in the system, the patient outreach people are not the most expensive people in the system. There should be a way that we can support the funding for those outreach people. And so, you know, some of that is that those pay for performance metrics that our health plans are now starting to offer us. I mean, it's not a huge percentage of our budgets, but it's starting to become a more robust. So just pointing out that, you know, Access now for many of us have that pay for performance measure, which is a year-on-year PPS bump. And one of their 3 metrics that they use to decide that is getting your percentage of your patients with A1C below a certain threshold. So that, you know, for us is close to $1 million. The Medicare Advantage plans, also many of them incorporate A1C control, but also the STAR measures, you know, that are triple weighted. Many of them are around medication compliance for medications that we would use with diabetes. So the diabetic medications, but also the statins, the ARB and ACE inhibitors that our diabetics are on. So you could sort of try to look at what is the realized income that you have from achieving those measures and say, okay, that's the, you know, if we want to get that money, we need to also fund outreach. And then knowing that when we do outreach, we're increasing our visit rates with our nutritionists and our BHCs and our providers. And, you know, Access helps us at this point by giving us that PPS rate, whether the visit is audio or virtual or in person. So those might be ways that you might make the business case for funding those kinds of positions. I don't know if that helps a lot at all.
I wonder if, Lisa, before you move on, Heidi is chatting in there from your office about using the internal lab to collect lab tests and avoiding another visit. Is that something that you can like tell us a little bit more about, Heidi?
I don't know if Heidi has
she might not have a, yeah.
Yeah, and I'm not sophisticated enough to look at my presentation and look at the chat at the same time.
Yeah. Well, oh, there we go.
One of the nice things about El Rio is that we do have labs at all of our sites. So if the MA inputs the standing order, they are able to go get their lab draws before they come to the visit. Whereas I know a lot of health centers use MAs or nurses for those phlebotomy type visits. So that is kind of an operational difference we have. Yeah. And I did see in the chat that somebody had mentioned using care coordinators. We have like a large RN care coordination staff, but that staff was being tasked with managing a lot of our COVID results and ensuring our patients got follow-ups for their COVID positive results. So we weren't able to use like the higher licensed nursing staff to do this work.
Okay. Yeah, good workflow kind of thoughts, at least, if anyone's thinking of changing some things around. So, and sorry to interrupt, but go ahead.
No worries. So if we, let me just move on to the last couple of slides, and then hopefully we'll have a chance to talk a little bit more. So this is just thinking about, you know, how telehealth and virtual visits can activate other team members. And I think we've heard already quite a bit about that this morning. It's just interesting for our own data that once we incorporated telehealth visits, we basically more than doubled our nutrition visits from previous years. So that was really effective for us. And part of it is that part of the way that we got more visits done is that there was a far fewer no-show rate and a far lower cancellation rate. So more patients tended to quote unquote show up for their visit if their visit happened through telehealth in their own home. Other members of the team who impact diabetes, as we talked about, just like with hypertension, the BHCs have a huge role in that. You know, the studies around diabetes control really suggest that patients who self-report the greatest psychologic, you know, barriers and issues are highly correlate with poor A1C control. So involving BHCs and motivational interviewing and dealing with challenges in life really does make for a more effective diabetes care team. And through telehealth, we didn't build our BHC encounters, but at the same time, we didn't lose BHC encounters. So that was another effective deployment of the telehealth. And we sort of talked about this, so I don't want to go back over that. I think we've talked both about the medical case for outreach and then hopefully some business case scenarios that might support that. So I'll stop talking and hopefully other people will start talking.
All right, so unmute and start talking. I like these questions. What a lot. So you know, how do you stage those interventions by other team members, the registered dietitians, behavioral health? Has anyone thought about that with your work with your?
And just to say a little bit more about that. So once we do, you know, it's labor intensive to do that outreach. So once we connect with the patient, we want to make the most of that connection. So not just the provider visit, but how do we stage the other visits to occur as well? We don't want to lose that opportunity and start back over from square one where we're doing more outreach to reach patients for that first time. So, you know, what at the end, should it start with the provider visit? And then the provider visit says, you know, I've been trying for years to get you to see the nutritionist. We have this new thing where they can call you and do that appointment with you. What day works well for you? So that's so closing the provider visit with sort of pitching the next visit. Or the alternative would be give them the same list of patients and have them essentially call out to patients and say, hi, I'm so-and-so, I'm the nutritionist that works with Dr. Sultani. She wanted me to call you to talk to you about diabetes. Does now work for a visit, or would you like to schedule it for, you know, such and such a date? So I'm just curious to see if people have found a way to bridge from between the different people in your care team. And I think that another speaker also sort of talked a little bit about that, how to connect the members of the care team around the patient in an efficient way.
Lisa, we've been doing some virtual integrated visits at Chiricahua. So like if I happen to care for children with type 1 diabetes, that's kind of a special interest of ours here. And so we often, at the end of the visit, if we identify that a patient could benefit from the dietitian or behavioral health, we use Microsoft Teams now. And so we'll chat in the Teams that we need a dietitian and the MA will reach out to a group of dietitians. Now that we're so spread out geographically and so rural, and there's some clinics that just would never make sense to hire a full-time dietitian for. So essentially our dietitians can cover any site now. And that's been the beauty of telehealth. And so, yeah, we do virtual warm handoffs. If the family is willing, we just say, hey, we can get you a dietitian today and bring them right on the call. It doesn't work all the time, but that's definitely been more common now with COVID. Mm-hmm.
And how do you know that the dietitian is ready right then? Is it a kind of volume visits type of thing?
So like I said, the provider who's on the video conference, what we do is into chat, we chat our MA, and the MA goes out and chats the team of dietitians to see who's available. And if anyone can take it, honestly. It's not like by site, we're just whoever's available, who's got a moment. So, and some are, yeah, I mean, some are busier than others, and you don't always get them, but there's been enough availability that it's been working this way. Mm-hmm.
That's really.
Have you ever done that with behavioral health, to bring in behavioral health?
Absolutely. No, but both of our integrated dietetics and integrated behavioral health. Yes, absolutely. Mm-hmm.
It's a really smart idea. I love that.
In the chat, it looks like Mariposa, the QI team's doing the majority of that outreach, which is interesting. What, Angelica, why you guys? Hopefully everyone else cares equally about the measure, right?
Hey, so I'm curious about, listening to folks talk about how well everybody works together. not that our folks don't get along, but quite honestly, the work from home has siloed us even further than we were previously. Mm-hmm. And so these presentations sound great. And the things that strike me are, number one, resources. We don't have an interoffice chat function. Number two, the size of your staff and your agent and how big your agencies are. Our agency is 50, but you know, many of those are admin people that don't do clinic-based care. We only have 3 medical providers, 2 MAs, 1 nurse. So our clinic staff is small. And then the other thing that I'm struck with is, again, this sort of reality of being siloed, because even though the majority of our clinic staff is here because they're essential, it just doesn't seem like things get communicated as well now because we're not all in the office in person. So you don't see people in the hallway and say, oh, hey, I spoke to this patient and, you know, this happened. And so can we get this going? Or it just seems like referrals between behavioral health and our clinic have decreased. The work that we're doing to get people on the phone has become difficult in terms of the technology on the end of the patient, but also, quite frankly, some of our staff has problems with technology as well. And so it seems like at this critical point in time, while we've realized that working remote, you know, works, it doesn't necessarily work the best for our patients. It works for us because we can get our admin work done. But in terms of connecting with patients and working collaboratively as a team, it seems like it has taken its toll, I think, with regard to the pandemic. So I look forward to everybody being back in the office. But again, you know, if people are doing telehealth visits, then will the necessary communication happen if patients are not in the office and the team isn't physically present with a patient? I mean, that's the thing that strikes me as I listen to some of the conversations is how well you guys have really managed the pandemic in terms of patient care. I think it's wonderful. We have not necessarily in Flagstaff, and I think much of it is, again, you know, the types of patients that we see and our proximity to the reservation and the extreme care that our CEO is taking with ensuring that our staff is minimally at risk.
Can I make a comment on that, Michael? We actually have improved significantly the communication between all our remote staff by implementing certain procedures within Teams. And I'm not advocating Teams as the only technology can do that, but we have created teams within teams, like groups within teams. And then we ask patients to have that Teams open all the time. So actually, it has helped us very much to improve the communication from the March to now. And you know, it's not just having Teams, but how do you communicate? So when someone reads, they put a thumbs up. When someone completes the task, they put a smiley face. You know, if you're responding to a specific message, you move the message into your own message. So there's not only the implementation of the technology, but how you're going to use it so that people that remain remote, and for us, a lot of people will remain remote for the foreseeable future, are better at feeling that they're a team and communicating and did someone do this? And then at the end of the day, you can track things that you were supposed to do. So I hear you. But we have worked a significant amount of time around this sort of remote staff communication. And for us, the Teams methodology has worked well.
Anyone else?
We did just start actually using Teams, and we're trying to work with it. I mean, it was just introduced to us. I do appreciate that.
Anyone else have some tips on how to break down silos in the health center that seem to be feeling wider? I think it's a hard question, and one that I think maybe if you really think of, I mean, all your health centers have gone through such change, not just now in the last few months, but over time. I mean, you've worked for various places, and if you can dig into your brain and those past experiences and think about what were turning points for teams that you've been on where things really started collaborating more, you know, we're kind of with COVID, with the pandemic, we kind of have no other choice now but to really collaborate. Like, it can't just be our good wishes and small little things that we try to do differently. So I think that even though that question came from, you know, a smaller site that's under resourced, like, I mean, I think even the largest of you would say you could use more resources, more people, more money, more funding. But it is critical that we look at that really honestly when we see that those silos are getting broader, and use that data. Because I love that you came into that question with, our referrals between primary care and behavioral health are down. I mean, that's a metric. That's something that you can really use to guide those decisions and know that this isn't just a feeling that I'm having. You know, that's not good. That's an important process measure that we're all looking at. So it also makes me, and I want to, Peggy, you can do your kind of final touches on that document, but it also makes me think of your team. You know, we have to remember the folks in our office now. I'm wondering, I'm going to launch a poll now. So in what ways is the practice is your health center addressing mental health and psychosocial well-being for your staff? This is something that's been popping up in a few different projects that we're looking on. I think as much as it's hard as a leader of a team to see your team not operating to the fullest, there's other stuff. We're all really strapped personally and professionally right now. Lots of things are going into why we're not as efficient as we need to be. And I see other folks are chatting in some other ideas. Great. I'm going to end that. And Peggy, why don't you show us our takeaways? Thank you very much for that discussion. That was great.
Sorry, we had to stop sharing the poll results in order to do this. So this is from Dr. Soltani's presentation. I actually have one I can show. This got a little dense, which was not the idea, but there were a number of good pieces. I think I'm just going to flash this at you to let you know that it's there, and we will get it back to you. But I do think that there are some good common themes across all these across all these different kinds of foci of the presentations that will really kind of knit together. So as we do the first layer of digesting this back for you and send it out to you after the meeting's over, we'll try to do a little bit of that knitting together. But and it's really to remind you about the things that you hear as you're in the midst of trying to actually pay attention to what you're trying to learn. So we'll take the notes to hopefully jog your memory afterwards as well.
So for now, we are going to take a break. We're going to come back at 11:10 Arizona time and hear from the National Association of Community Health Centers and Blue Novo. So go enjoy your break, relax, and come back ready to listen about health IT, optimizing data. All right, I'm seeing cameras turn back on. We're going to get started here in a minute. There's a neat question in there about, we're offering things for our employees, but nobody's taking us up on the offer. So if you have ideas about how to get your staff to join in COVID mental health sessions and things that you're doing, that would be a great thing to share on that chat too. And I'm going to launch one more poll here. We'd like you to tell us how much you're taking care of you during this time. Results are coming in. And I'll give you a sneak preview. It looks like some people are asking their staff to do something that they are not doing themselves, which isn't surprising, but, especially for our, come on, those of you who are trained as doctors and nurses, you put the oxygen mask on yourself first, but before you help your small child or the person sitting next to you. So we really do hope that you do something to take care of yourself a little bit more. And if you are someone who selected a great deal or a lot, I'm really doing good at this, chat in, how are you making time for it? What are you doing? And maybe what it's helped you learn as a person and as a leader of your health center and as a member of your family and as a friend or a husband or a wife or a daughter. And because, we want to share those things with our friends too. So we are going to hear now from the National Association of Community Health Centers and Blue Novo, and they're going to talk about leveraging health IT so we can track and our improvement efforts. And why don't you all just introduce yourself? I know there's like a panel of you, a whole group of folks who are going to be talking and asking questions, and so you figure out how to introduce yourselves and share your own slides there.
So this is Julia Skapik. I'm the Medical Director for Informatics for NAC, the National Association of Community Health Centers. I think, is that right, Ray, that we're at the front end of this discussion? So I'll just tell you a little bit about myself. I'm an internist and clinical informaticist. I did some work after my residency with the federal government, the Office of the National Coordinator for Health IT for a decent stint. And then I've been at NAC since the last year. And at NAC, we're excited because we're building a nationwide informatics infrastructure to support health centers, networks, and PCAs. We have a COVID-19 project that the kickoff meeting is today, but of which we believe there'll be several phases, and hopefully we'll have the chance to work with all of you as part of that or as part of one of our many other public health efforts. So I'll kick it over to Raymond for his.
Yes, thank you very much, Julia, and good afternoon. I would say good morning or almost afternoon to everyone here. Thank you to Lindsay, Lainey for setting all of this up. My name is Raymond Uy. I'm a trained physician. I did a bioinformatics fellowship at the National Library of Medicine. And I am the physician informaticist under Dr. Julia Skapik's team with the National Association of Community Health Centers. And like what Julie said, we have a lot of HIT initiatives in NAC. And I'm going to share my screen right now, if you don't mind. And we can start. Yeah, so the topic for today is really leveraging health IT to track, improve, and manage health outcomes. But we wanted to really focus on how you use HIT for continuing quality improvement efforts. So these are our goals for today. It's really acknowledging that technology is important to 20.
No, I think we may have lost, you hit mute accidentally there, Raymond.
Yes, there you go. Zoom kind of quit on me, so let me. share my screen again.
See, even the informatics people have issues.
Thank you for your patience, everyone. And yes, everyone's using IT nowadays. We do teleconsults everywhere, and even our kids are maybe starting school right now and doing their school online. So again, it's acknowledging HIT is an important tool for managing and engaging patients, the role of data in QI improvements, and what strategies you can employ to optimize your HIT utilization. So we're really gonna kind of give you a macro perspective, and I'll let Lunovo show some examples later. First and foremost, when you're trying to do some HIT initiatives, first you have to understand that data is not stagnant. A lot of health providers would enter their stuff in the EMR, and then it kind of disappears into the void for some people without really knowledge of what happens behind the scenes. But specifically for quality improvement efforts, if we're trying to do quality measures, we need to find the data. As you can see on the left, it's where is the data actually? You enter it in the EMR, you do some typing, some clicking, and then click send or whatever, and then what happens? And number two, how is the data captured? So we're capturing clinical data, we're capturing vital signs data, we're capturing survey data, for example. How are we capturing that data, and how does it fit into the workflow? And that, of course, everything else in the middle, 3 and 4, would be something that your data or IT team would be doing. But after that goes through your data teams, how is the data reported? How is the data understood? And how do we act on the data that we get? But before you do that, we're going to focus on first, how do you find the data? And how you do that is first you have to understand and try to define your metric. What are you trying to measure exactly? So in QI quality improvement efforts, we look at some quality measures, right? In this case, our example would be this quality measure of trying to figure out BMI percentiles for children. So there's a measure description, right? Pediatric patients 3 to 17 years old who's having an outpatient visit with their PCP, OB, or whatnot. And we wanted to look at the percentage of patients with BMI documented, for example. A percentage of patients with counseling for nutrition or counseling for their physical activity. And how do you find data on those things? And first and foremost, again, there's clinical workflow. There are the things that we see that's happening in the clinics, the things that's happening right now during our telemedicine or teleconsults. But what's happening in the background is, again, how are we capturing the data, or what specific parts of your EMR fits into that everything that's happening, like the operational processes or the clinical workflow processes. You can see on the left-hand side on the first column would be your processes. First, patient checks in, pre-planning visits, and we heard a lot about what kind of things that the immunization and the diabetes management and how all of that fits right now during this pandemic. You have your pre-visit and providers. So all of these clinical processes, but what's difficult is these are very easy and tangible things, but when you zoom in, you can see right in the middle would be the data part, the data side of things. Who's inputting this data? Who's entering these data? And what are the configurations in the EHR that captures these kinds of data? And what are the clinical workflow considerations you have to take in when doing all of these things? For example, in your medical assistant here or the nurse would be to report or intake any of the patient's pre-visit needs. Or for example, still the MAs are trying to do triage during COVID, or trying to do screening and trying to figure out the complex necessities of patients who have a lot of comorbidities or have difficulties in technology, for example, or difficulties going to the clinic. And there are different ways for you to figure out places where you can visualize or understand what happens to your data afterwards, or how this overlaps with your clinical workflow. On the top, you can see which data activities your EHR is doing. What required data is collected in the measure, and how is it being collected? Which people are capturing or inputting the data? What EHR functions or configurations are supporting this data collection? Are you just inputting it with in your workstation? Are you using tablets? Are you using mobile health devices? Or are you using BYOB or bring your own device? Is it the patient side? Is it the provider side? Is somebody else doing it for you? And what parts of the workflow can you change or can you add value to so that you can capture this data properly? So I wanted to demonstrate, show this image to everyone. This is called a value stream map. It looks very complex, but what I wanted to highlight here is that you can see the middle side would be reception, going to the right, referral, and going to the hospital and stuff like that. Those are things that are happening physically, or these are your clinical workflows. But then you can see there's so many other lines. You can see the red arrows and the blue arrows. And those are data streams. Those are places where your data goes, or that's how your data travels. And it goes into so many places. And sometimes it doesn't go anywhere at all. Sometimes it's siloed in different places, and you're not even sure where it is. Is it in the cloud? Is it on the internet? Is your data hosted in your clinic? Is your data hosted outside? So there's all these things that are difficult for, I guess, non-IT driven folks, right? It's always a treasure hunt. Like where do you get the data, and how do you capture your data? There's the front end, the user, and then there's the back end that everybody else, except maybe your your data team or your health IT team would be looking at. It's really a mess. It's just like the kitchen, right? There's so many things happening in the back. And when you capture data for example, quality improvement measures, there's a way for you to abstract free text or data that's inputted in your EMR or however it's configured to something that your computer or something that the EMR understands. So in this case, on the left-hand side would be free text. A lot of providers write a lot of free text. They copy and paste stuff, and it happens everywhere. But then on the right-hand side would be a machine-readable version of everything that you're inputting on your EMR. So these, on the right, you can see these numerical codes for specific concepts. For example, the age of more than 40 years old, and then there's a number there. That's a SNOMED concept, or a standard, international standard, that machines are able to use that concept and create clinical decision support algorithms. Or, for example, if there's your patient's coded for example, a high risk for COVID, then you can use these machine-readable codes to be able to push or to leverage those codes to push maybe reaching out to those high-risk patients in your clinics. And not just for COVID, this can apply to your to chronic disease patients or diabetic patients, for example, or your pediatric patients who need follow-ups for immunization. There's so many things you can do with it. But understanding that data is read in this way is very important, and capturing data properly is important too. Everybody knows the left-hand side would be your billing codes, right? Your ICD, your CPT codes, procedure codes. What sometimes is missing, or what sometimes is overlooked, would be the ones in the middle, which would be your SNOMED CT codes, your LOIN codes, your MEDRA codes, which is for research, and your RX norm, or your drug codes. And then you go on the right-hand side of this slide, you can see there's a lot of question marks. And you can see all of our EMR vendors here: Epic, Cerner, ECW, NextGen, Allscripts, Athena, et cetera, et cetera. Not all of them natively support the stuff in the middle, SNOMED codes, LOIN codes. There's an internal code system that EMRs are using that sometimes makes it difficult for data people, your data team or clinical informaticists to dive into specific parts of patient databases and do some research or submit quality measures. And that's a big difficulty that we're seeing. And how can you change that? Maybe you can talk to your vendor. Most of your data team might not have a clinical background, so there might not be any crosstalk happening between your clinical workforce or the provider workforce and the IT workforce, right? So how do you leverage and how do you liaison between those two teams is a very important part. So communication is very important. What happens with measures a lot is there's a lot of internal data mapping that happens. So when you type something on your electronic medical records, you don't necessarily have a drop-down box for the machine to understand that, hey, this diabetes is not just, it has an ICD code, it also has a SNOMED code. And you get, so billing codes and problem lists and stuff like that, if you're trying to capture it and report, for example, UDS measures or quality measures, it might not be captured immediately during the process of entering it into the EMR. So there's a lot of abstraction happening in the background that's behind the scenes, or a lot of mapping behind the scenes to actually do quality improvement reports or reporting. It's especially important during the times of the coronavirus pandemic, where we're getting a lot of data on patients and getting testing data, but how it's sometimes a big problem of how to extract that data from your EMR vendors or your patient databases, so it can be reported to public health agencies or to dashboards, so like the Johns Hopkins visualization dashboard. And that's not automatic. There's a lot of curation that happens behind the scenes, and that's a big problem. If you read a lot of publications on the happenings of data behind the scenes for health data, public health and epidemiological reporting of patient level data, that's the lowest. The highest would be billing, of course. And I'm not saying it's not important, but for research and public health reporting, the data is not being utilized as much, and we don't think it's right. And we're seeing the effects right now. You can see on the top side here would be just to illustrate to you that it's a very complex web of terminologies that are happening behind the scenes on the back end of things. But what we wanted to highlight here in this slide, what I want to highlight in this slide would be, again, trying to figure out what happens to your data, like when you put it in your EMR. And then to add to that, if you ever seen a data pool of one of the biggest issues on why data is missing is because of workflow. You have providers being overburdened by documentation and whatnot, but how do you fix that? So maybe applying lean methodologies, for example, doing some workflow analysis, overlaying your clinical workflow with how the data flows into your system would be very beneficial, not just for the provider side or the clinical side, but for the health IT side or your data teams. So what's MUDA and MURI? So MUDA is waste, trying to find wasteful activities in your workflow, and trying to figure out how to add value into those wasteful activities, such as maybe this call does not really add value to the care process, stuff like that. And you can only do that by mapping your clinical workflows and your data workflows. Next would be MURA. What's MURA? MURA is an imbalance. You can see, again, providers are overburdened with data entry and stuff like that. But maybe you can offload those activities to other people in your organization or in your clinics. Maybe the MA can help with that. Maybe the nurse can help with that. Maybe your data team can help with that too. And MURI is, again, overburdening, like when you can see people getting stressed out, and they're operating at more than 100% of their daily capabilities. Again, trying to visualize that, and remember, if you guys remember the map from earlier, it's how you define and how do you find places in your workflow that you can improve on and to add value to. Again, I guess don't let your data flatline. I think understanding, again, the pulse of your data, where your data goes and how you capture data is important when you're leveraging health IT with not just quality improvement measures, but also for pushing information to your patients or getting patients back into your clinic during scheduled times or when you need some interventions done. There's a concept called Kaizen, which is it means continuous improvement. And you should, clinics and us as providers or as part of the clinical workforce in our clinics, would be to iterate and to try to continuously improve by trying different things, and don't be afraid to try something out and measure it and see if what works or not. and considerations for the future, trying to understand how the data flows behind the scenes is important, especially now during 2020 and beyond. Right now, we are getting healthcare encounter data or patient level data, but in the future, maybe 10 or 20 years from now, we're going to start capturing more complex kinds of data, such as genomic data, other outcomes data, biometrics data. Like earlier, there's a lot of conversations about self-measured blood pressure and these different devices that our patients are taking home, taking back to their homes. Does that really integrate to the EMRs? Do the providers actually look at that data? If there's something in the self-measured blood pressure, like a blood pressure spike, should we alert providers about that? Is that overburdening, right? And then there's consumer data and social media data that we're looking at for tracking epidemiologic data. So there's all of these data considerations that everybody, like clinics, need to look at in the future. And I guess that gives you a macro perspective of why or how important it is to look at the different capabilities of your health centers in terms of technology and really leveraging that and brainstorming and working with your IT teams to pave the way. So that's pretty much it. I think Blue Novo will be able to expand on this further and try to touch base with what's happening really in the field. So that's my perspective. Yeah. So Julia.
So I'll unmute there. So I think we should pass it off to Blue Novo, right?
Perfect. Josefa, do you want to share the screen or should I?
If you have it up, go ahead and share it. It's fine.
Right. And okay. Okay. So my name is Ana Maria Izquierdo. I am the Chief Medical Officer for Blue Novo. And we are going to take you from up in the big stratosphere that you just heard in terms of data down to the day-to-day implications of that conversation. So as I said, I'm the Chief Medical Officer of Blue Novo. I am an internist and geriatrician, and I lead the clinical transformation and analytical practices within Blue Novo. Josefa.
Thank you, Ana Maria. Yeah, so my name is Josefa Desaji. I'm PharmD, and I am the telehealth and BD lead at Blue Novo. And excited about today. So I want to thank AACHC for asking us to present, and thanks to the NAC team for doing such a wonderful job for teeing it up.
So we are in the same learning objective, so we won't spend some time with that. So Josefa is gonna guide you a little bit through the big implications for our health centers, and then we'll go into ideas of how to make that happen in your day-to-day.
Right, so I mean, one of the things that's, FQHCs are the largest primary care provider network in the country, right? And every time as I've gone around in the FQHC world, and CEOs always talk about, well, we're all about value, we're about quality at our FQHC. Well, what does that really mean? And the idea is that you shift into a value-based system, which is really a measured improvement in a patient's health outcome, as opposed to the cost of achieving that improvement, right? So how can there's always that gap, and how can we take that and get to a place in a value-based system where we're profitable? So taking quality measures, taking RCM, the training and awareness, and getting to a place where you are profitable and you're actually improving the lives and health outcomes of your patients. And in order to do that, then, it's very important for FQHCs not just to be the healthcare providers of last resort, but also the healthcare provider of choice. And so you want I always say, and what's the best way to do that? And data, as the NAC team really pointed out, data is going to be important, and technology is a really good tool in order to capture that data. So as you start, we've seen in COVID, you know, starting to use telehealth. I think the next shift is going to be, and I've heard a few of the presenters today, I think Dr. Sultani as well, talk about this, the idea of getting remote patient monitoring, and how can we capture data from a patient, not just when they come in to the clinic, but getting a continuous picture of that data, and how can we use that to be able to improve patient outcomes. And so once again, using technology to bridge that gap. And so as an organization, as you continue to move through, you know, and we talk about quality and we talk about value, can everyone in your organization, you know, recount that, or be able to, from the front desk staff to you as the quality people, everyone in the organization, do they understand what exactly it does that mean when we talked about a value-based goal for your organization? Is there a timeline? How are you going to measure it? Who has ownership of that goal? And once as we move into this and you start thinking about that data, can you tell me, you know, not only the patients who are on Medicaid and Medicare, but who are your private patients? When did they come? And have you had any patients that have come in? Did they come back? And when you start to think about contracts, and as you talk to payers, and how do I then negotiate contracts, having data on your patients, and data that is clean data that I can actually, you can use to make those points for why you as an FQHC, and make points in negotiating better contracts as you move towards value. So with that being said, I just wanted to give you something to think about, as then Dr. Izquierdo is going to take a deeper dive, and we'll go a little bit more into the nitty gritty. So Dr. Izquierdo. I think you might be on mute.
Okay, can you hear me now?
Yes.
Okay, so there are two steps that we're going to discuss a little bit going forward. One is, how do you enhance your analytics? And if someone was expecting us to talk about how to run reports and write them, wrong meeting, but just a sense of how do you set your analytic infrastructure in your organization. And very closely tied to that, how do you optimize your EMR to collect the information that you need in the least amount of burden for the people that are already a little bit burdened? So first, and this for the nerds in the audience, is quantum physics, right? When you observe something, you can change it, but you cannot change what you cannot see, right? So you know, this is true for the subatomic world, but it's also true for FQHCs. And the things that you want to change, the things that you want to improve, need to be visible to you. That doesn't mean that you have to measure everything, you know, since the inception of the FQHC, but you need to focus that analytic strategy around the things that you truly want to change. How do you set up your analytics? And I think you need to make buckets that are very clear, because different people within your staff will access different analytic tools. And there are three main buckets, right, that you need to think through. One is the overall dashboards, the strategic dashboards, the information that the leaders in the organization require to make solid decisions. So this is the data that you present to the board. This is the data that you use in your budget season. This is the data that you may use to write grants. But this is the sort of overall data that you look at on a regular basis to manage your organization. Generally, dashboards have three sort of elements. One tends to be your operational, so your patient demographics, your visit counts, and all those things go into the operational dashboard. Then you have the clinical dashboard, and that includes not only somatic health, but mental health as well as dental. And then you have the financial dashboards, okay? Again, the goal of these dashboards is not to go down to the nitty-gritty to figure out who is missing a mammogram. It's to give a sense of direction to your organization. The second one is the day-to-day QI. And whereas before we were using tools like Power BI or Tableau or Azara or i2i, here we are using more of the your registries or the population health element of your i2i or the population health tool within ECW. They're a little bit different because an important piece of this element is that you can drill down to the patient level. So it's not only telling you, your mammogram rate for this month is 70%. It's telling you who's missing that mammogram, okay? And then the third step, and I think we don't look frequently to this step, but it's important, is how do you have access to quality data at the visit level? And for those of you that speak Spanish, there's a saying in Spanish that I love, which is aquí te pillo, aquí te mato. It translates terribly. It translates to, I find you here, I kill you here. But it's this idea of, I will do what I need to do when I see you. Why do we need to schedule a visit for the mammogram and a visit for the diabetes and a visit for the PAP? Let's do everything in one visit. And once the patient is there, let's offer absolutely everything we need to offer in terms of complying with excellent quality care. So, your flow sheets, your alerts, your in ECW, it's CDSS, in others, it's others. But how do you set that in a way that allows for the frontline staff to access that data without having to run a report or without having to create specific data fields, right? Things like reminders, right? If I know that I need something in, I need to check on my hepatitis C patients to see if they have had a viral load in the last 6 months. Well, I should create a reminder in the system for myself. So these three levels are important because if you don't have a tool that can speak to each one of these elements, you're going to struggle with understanding where you are as an organization. And by the way, if you want to type questions as we go, please go ahead and interrupt me. One of the important things that I want to encourage you, in analytics, I see this all the time. Oh, this sucks, it doesn't work, let's buy a new tool. And it's fine if that's how you want to do it. But I think there needs to be a work of optimizing the tools that you have to the maximum so that you really figure out, is this because the tool I have is not quite working for me in the way it was intended to work for me? Or is it that it has some abilities that are unknown to me? So the idea of looking at your tools and figuring out, can they do a better job for me, is very important. So let's talk through what optimizing means. I actually am a practicing clinician, and also a nerd. So for me, quality is personally important. But I can also tell you that when I'm busy and I'm behind in my schedule and I have someone asking me to do 2 more things that were not in my schedule that day, I'll skip over things because I just don't have the time. So a way to avoid this is to automate. Whatever you can automate that doesn't require someone to remember something, automate. And, you know, our current EMRs have much more capacity to automate that we give them credit for. So for instance, in NextGen, create orders that are tied to specific CPT codes in the backend, CPT type 2, right? Create procedures in your system that you can tie to a CPT code. I will tend to give more geriatric examples just because I'm a geriatrician, but you can create a procedure that is fall screen. And when you order it in the backend, it tells you what fall it was. Or in ECW, you can create a rule in your rule engine that says, if this shows up in the fall screen, add this code to my system. So automate as much as you can to make sure that there's documentation of the things that you're actually doing in a way that can be captured. You know, maybe 10 years down the road, we'll be talking about artificial intelligence, and when we free text something, it will be able to be captured. But right now, it's not the case. So think through what things you need to do to automate your processes. Another important thing that I feel very strongly about is segmentation. You know, not everybody needs the same thing. Sometimes you just send a reminder to someone and they'll do it for you, okay? Now, why do I need to add all these patients that would naturally do things to the outreach person? We don't, right? We just segment those that will receive a text reminding them that they're due for a vaccine, and they will make the appointment and show up. Those you don't need to touch. Maybe those that need a second reminder and a call, and then maybe those that they don't come no matter what you do, so you outreach to them in a different way. So just figure out what the role of segmentation is in your organization, because unless you're an FQHC I've never met, you don't have unlimited resources. So allow the patients to help you through some of these quality things, you know, if they can. And then reserve your resources by those that are having more struggles. And then again, reserve the personal touch for your high risk. As we move more and more into value-based purchasing, those are going to be the patients that are going to be harder for you to take care. So I actually joined the meeting a little bit earlier, and I was hearing about the diabetes outreach efforts. Again, do you need that for every single diabetic in your practice? Or you can actually focus a lot of those more personal touch resources for your high risk and you know, use automation for those that will follow you with very little encouragement. So second is the big second bucket is make it easy for your staff. So if you have a way to document something that is quality based, that requires 10 clicks, the likelihood of that happening decreases as you add clicks. So as you look at how your infrastructure works, just make sure you reduce the number of clicks, make it easy, integrate it. Allow for multiple options. So a while ago, I did some training on reliability, and reliability relies on having very structured processes. The reality is that if you look at adult learning science, it is, it's not how it works. If you build in the system 5 ways of doing things, what will happen is that based on where the provider is or where the provider is comfortable or where your staff is or where your staff is comfortable, they will choose one or the other option and it will come to the same outcome, which is you have the data that you want. And again, automate. You'll never hear me stop talking about automation. So I would like to stop 1 second. I've heard a couple of comments come up. And then let me, pull the chat. Okay, we're good. So let me give you some examples and then we can chat. So this is an example, and sorry, the screenshots are in ECW, but to give you some sense, there's some templates here that have nothing to do with clinical documentation and are all about coding. So this one, for instance, when you pull this template in, it just says, we're seeing the patient within 7 days of discharge, and it adds this code. There's some chunk of money associated with this. So we made sure that we made it easy for the providers to document that and to code it properly so that we wouldn't miss that money. This is a very interesting one because it does 5 things at the same time. So this is an alert that reminds people that once a year they need to do healthy eating counseling. When you click, it allows you to add the ICD code that will actually give you the credit for it. And it also enters a procedure so that you know the last time that you did that. So you build multiple things that are all working towards you being able to get your UDS measure taken care of and the provider having an easier time to do that. This one is very specific to eClinical Works, but again, this idea of automation. So you can create rules to enter the specific Z codes for obesity. That a lot of Medicaid MCOs love you to add those things. Like for me as a clinician, why on earth did you add it? I have the BMI up there. And I already said that I was doing counseling. Why do I care what specific, ICD that is tied to? So what you do is you build it in a system in a way that it adds the code outside of the visit. It's there, you can submit it with your claim, but the doctor didn't need to think about it. So again, automation is very important. Use your patients as your allies. Patients will do more than you give them credit to, specifically the low risk and easygoing ones, but use them. Why not have them do some of this? And a lot of it is they don't know what is due or what they have to do. So just let them know and then make it easy for them to have it done. If they have to call 5 times to get an appointment for the mammogram, guess not, it's not happening. So include them and make it easy. And then finally, I'll just talk about the optimization of all the elements that are technology-based. So for the portal, make sure that you look at functionality. There are portals that allow you to have the patients update their information. So that makes documentation easier. The messaging in terms of ensure that you have quality messages that go out from your organization. You know, I remember once that when we added the automated messaging about shots, I start seeing people, so why are you here today? Oh, because you told me to. I told you to? What do you mean? Oh, you said I needed to come and see you to get my shot. I'm like, oh, well, look at that, right? So just make sure that you include quality measures within your messages and consider doing patient satisfaction with automated messages. That will save you some time. And then as we were talking, as we were going, alerts, procedures for quality purposes, templates, order sets, defaults. I mean, please make sure that you use all those things to the extent that your current system allows, because we underutilize all those things significantly. So very briefly, a couple of things that I think are important in this and I've heard some of these conversations, but again, you know, what is coming for us in terms of analytics, you know, risk stratification is going to be very important. But if you don't, if you're not able to have the infrastructure to do your current analytics, it will not support the other. And as you go through all this, please make sure you have some staff metrics that you track to make sure that whatever happens with your staff doesn't catch you by surprise, whether it's satisfaction or well-being surveys or whatever it is. Just make sure that your staff well-being is measured also as part of your big analytics strategy. So I'm going to stop talking and we can.
Well, thank you very much. I think Raymond's very curious about what everyone's challenges have been. And if you can chat those things in, it'd be great. And I'm wondering, Peggy, if you can show that the summary document so that folks, especially those of you who don't dig in as much, maybe you're not an informatics person and you're not in the quality department, and all of this hopefully gave you some good ideas about, oh, that's why they're always telling me no when I ask them for things, or that this is much harder than you think. But thank you both to NACHC or NAC, I'm not sure which way to call you, and Blue Novo, that was great. Peggy, do you want to, we're getting close to wrap up now, so do you want to, I think that for this, we can send this document out, and it's really intended to help you think about what you can share with the other members of your team who don't care as much you think about your role, but they probably do, and give them to be able to have some specific action items and things for that. And is there anything else, Peggy, since you were the one doing that, that you want to kind of final words or thoughts for folks about how to put those things into action?
Yeah, well, you know, it actually comes down to that kind of last conversation in the previous, you know, in the previous time slot, which is around culture. Right now, again, you know, barns burned down, we get to look at the moon, but we're all, you know, there is a lot of pressure on how quickly we can adapt to do this effectively. It's pressure from the work perspective, it's a lot of pressure from the personal perspective, because you're all doing this work because it matters to you. So I think that with that, you know, Rebecca was saying as we kind of walked into this particular room about on the airplane, they do say, put your oxygen mask on first. I think that that's important for you personally, but I also think it's really, really important to think about how are you nurturing, you know, very touchy-feely talk, nurturing your team. How are you intentionally creating the space for your team to really think about these stretch ideas, because this is a window of opportunity to get some really cool stuff done, because everything has changed and it will stay changed for a while. And your job is to figure out what of those changes are the ones that are going to be critically important to sustain. What are the things that you have to have once this particular pandemic is through? You know, what are the things that you want to keep, and how are you going to document it? What data are you capturing to show that? How are you looking at your outcomes that will really be able to demonstrate that, yes, it does cost more money for Darlene and the Chiricahua gang to spend 30 minutes on a well visit, on a planned visit for you adult chronic care folks? How do you re-engineer your processes so that getting those lab tests becomes standard practice, so that you're not wasting your time afterwards chasing them down? how do you build those things into your everyday workflows so that when the world kind of settles, you get to hold on to the things that you need to deliver that excellent care? I think that I will stop there because I could talk about that forever, but it's almost noon, so I'll hand it to Lainey.
Thank you, Peggy and Rebecca, and our presenters, and to all of you who were a part of this today. I'm really happy to see this diverse group in the call today. So often I get to see all the QI folks, and I don't get to see a lot of the other individuals. And we always talk about how important it is to bring everyone else back to the room. So this made me very, very happy. I know there is a poll up. So if you would go ahead and complete that, I'll talk briefly about some follow-up items. We will be sending out a survey that is for CEs. So we'll have CEs available for medical and quality. So you will have to complete that survey to get those. So please do that, keep an eye out for that. We will also send out a link to the recording. We'll send out the chat box information. We'll share the resources that were shared today. We'll also share the task list that Peggy's been working on this whole time. So we've got a lot of stuff coming your way, but hopefully good stuff, and that was really the goal today. So let's see, from my perspective, I can only see the behind the scenes poll stuff, but Rebecca, is the poll up for people to see results? Okay, great. Perfect. Is there anything else that Rebecca or Peggy that you want to touch on before we close out? Because I know we're at time.
Well, thank you guys for everything you're doing for us. I'm a regular person. I'm not like a doctor or any type of clinician. So thanks for everything you're doing every day to keep us all safe. So.
Now, did we already administer the post tolls? And I just missed it.
You're a little submarine-y.
Oh.
Yes.
I will look to see if those post tolls are, let me see here. We have the post polls right here. Okay. Thank you for that reminder. Yeah. So take this one too. Please.
And scroll down, 2 questions.
I have to jump off, but thank you so much for having us, Dr. Sked, and I really appreciate it. And if you have any questions, I think our contact is in the chat box. Feel free to reach out to us. More than happy to help in any way that we can. Stay safe and continue the good work. Thank you, guys. Cheers.
Thank you.
Bye.
Great. So we'll give some time just for these polls to close out, but I guess we can say if you've completed the poll, thank you for attending, and you're free to hop off. So thank you all.
Okay, I think we're not getting any more answers, so I'm gonna close this off as well. All right, thanks everybody. Bye-bye.